Okay. Hi, Huma ma'am. I think Sabiha ma'am and Page madam are online, like they have joined.
Good afternoon, Page ma'am and Sabiha ma'am. Prachi here. Good afternoon, ma'am.
Good afternoon, everyone. A warm welcome to all of you. For today's session, we have judges as Dr. Radhika Page, Madam, Consultant Oncopathologist, National Cancer Institute, Nagpur, and Dr. Sabiha Maimun, Ma'am, Professor and Head, Department of Pathology, NKP Hospital, Nagpur. So let us start with the first paper presentation, and it is Dr. Achal Gupta. Dr. Achal Gupta, are you there? I think you have joined. Please share your slides. And about the rules, you will get 7 minutes for presenting your paper and 3 minutes will be for the question and answer session.
Dr. Achal, do you need any help?
Yes.
Yes.
Good afternoon, ma'am. Hello?
Hi.
Yeah, you're audible.
Yeah, okay. Ma'am, should I start?
Yes. Start.
Okay, ma'am. Yes, ma'am.
Yes.
Oh. 1 second, ma'am. I'm just sharing my screen.
No problem. Do it.
Oh. Ma'am, is something visible on screen?
Dr. Achal, we are able to see your presentation.
Okay, ma'am. Ma'am, should I start?
Yes.
Ma'am, so the title of my presentation is Effect of Neoadjuvant Chemotherapy on the Expression of Hormone Receptors, that is ER, PR, HER2, and on proliferation marker, that is Ki67 in patients with locally advanced breast cancer. So, ma'am, locally advanced breast cancer is basically refers to the most advanced stage of non-metastatic tumors, and it includes a wide variety of clinical scenarios. So the importance of administering neoadjuvant chemotherapy is advantageous to locally advanced women with locally advanced breast cancer, and it can render inoperable.
Block the front 405.
Sorry. Hello.
Oh, 8 pixel. आणि अजून 3 दिवस ठेवलं तिथेच काय कर बोला अजून पण खराब होतं
Ajal,
Yes, ma'am.
yeah, you can continue. Continue better.
Yes, ma'am. Ma'am, so the most important parameters was to find the treatment in breast cancer. They have been found out to be ER, PR, HER2, and KI. So, ma'am, it has been postulated in various studies that alteration in receptor status following neoadjuvant chemotherapy has been observed. So, the changes in these expressions, they can influence the clinical decision of adjuvant molecular and hormonal therapy. So, ma'am, the aims and objectives of my study were, the aim was to study the change in receptor status in these patients. And ma'am, so the objectives were to study the expression in core needle biopsies.
चांगलं होतं biopsy तेवढं आलं नाही.
Then to study the expression in post-mastectomy specimens after administering chemotherapy, and then to compare these changes of expressions. So, ma'am, the study was conducted in the Department of Pathology in collaboration with the Department of Surgery in my institute, which is Pandit B.D. Sharma, PGIMS Rohtak, ma'am. Ma'am, the study basically comprised 52 cases of patients with locally advanced breast cancer who received chemotherapy, and 20 were control cases who did not receive chemotherapy. So, ma'am, we took 2 specimens. We took the true-cut biopsy specimen and then the mastectomy specimen. And, ma'am, then we studied the expression of ER, PR, HER2, and KI in both the specimens for all the cases and controls. And then we compared the change in expression. So, ma'am, what I observed was comparison of ER expression among the cases. So 15.4% of the patients, they changed from ER positive to ER negative. Ma'am, ER expression was according to the ALRED scoring system, more than 3 I took to be positive, like 3 out of 8 score. So, ma'am, 15.4 changed from positive to negative, and 1.9 they changed from negative to positive. So, on applying stats, the change was statistically significant. So, ma'am, then similarly, when I compared the changes for PR, 9.6% showed change from positive to negative. So again, it came out to be statistically significant. Ma'am, in case of HER2/neu, 19.2% changed from positive to negative, and 11.5 from negative to positive. It didn't came out to be statistically significant in my study. However, in a few other studies, it has come out to be statistically significant. Now, in case of Ki67, again, 30% changed, and from positive to negative, and 11.5 from negative to positive. So again, it was statistically significant. So, ma'am, previously it has been demonstrated that chemotherapy causes certain changes in the cells, like enlargement of the nuclear, swelling of cytoplasm, which these changes then further may affect the tumor behavior and therefore the treatment plan. So, according to the same Gallen conference in 2013, the IHC results of patients who underwent core biopsy, they were negative for both ER and PR, while the post-operative, they were positive for ER or PR. They were able to receive treatment with tamoxifen or aromatase inhibitors. So, hence, if the conversion is there from negative to positive, it can benefit the treatment of these patients. Ma'am, similarly for HER2 new, like after core biopsy, if it is negative for HER2, but surgery, if it was positive for HER2, then they could receive Herceptin. So close observation benefits to the patients. And ma'am, so similarly in my study, the positivity of ER decreased from 48% to 34%. So ma'am, other studies there was a study conducted by Wu et al. So ma'am, in that also 7.7% of the cases they showed change from negative to positive. There was ma'am another study conducted by Dede et al. And he showed that 5.7% cases showed conversion. So our study, the results are in concordance with the other studies. For PR also, in our case, the positivity decreased from 48 to 38. So similarly, Wu et al. Found that positivity decreased from 51 to 42. However, ma'am, there was a study conducted by Dede. He found out that it was not significant, but many other studies are in concordance. Similarly, for HER2 new, in our case, it decreased from 42 to 32. And there was another study conducted by Torcher et al. Who evaluated these changes with IHC methods. And they showed that this positivity changed. But again, his results are not statistically significant, as ours are also not statistically significant. Ma'am, then in case of Ki67, in our study, the decrease was from 69% to 50.
Go.
Yes, ma'am.
1 minute to go. Continue. 1 minute.
Yeah. Yes, ma'am. Ma'am, then for Ki67, Wu et al. Conducted a study. 21.1% of the cases they were converted from positive to negative. So according to him, the decrease in positive was from 65 to 43. Again, by Peng et al. Said that the decrease in the positive rate by Ki67 was the most significant. So ma'am, in conclusion, I would like to say that our study demonstrated the existence of discordance in hormone receptor status, that is in ER, PR, HER2, and Ki after neoadjuvant chemotherapy. So these findings might help optimize the choice of therapy and improve the treatment and prognosis of the patients.
Okay.
That is it, ma'am.
Thank you, Achal Gupta. Now
Yes,
the paper is open for question and answer session. So please, Dr.
Yes, ma'am.
Radhika ma'am and Dr. ma'am.
Thank you, Dr. Achal. It's an interesting topic, but I have few questions for you. Number
Yes,
one,
ma'am.
what is tumor heterogeneity?
Ma'am, tumor heterogeneity is that the tumor is affected by multiple factors. The causative agents are multiple factors. It cannot be determined by only one factor. That is.
Have you done ERPR receptor status at your own institute, or was it outsourced?
No, ma'am, it is done in my institute only.
Okay, so when you are doing it on a core, you are not doing it on the whole tumor, isn't it? So
Yes,
by
ma'am.
tumor heterogeneity, it is mean that there are different clones of tumor in the same sample, right? So how
Yes,
do you
ma'am.
say that the change in receptor status is because of NACT and not because of tumor heterogeneity is number one question. And number two is that Ki67 was expected to reduce because it's a proliferative marker and it is bound to reduce after NSCT as a treatment response. If
Yes, ma'am.
Ki67 is not reduced, it indicates that the therapy is not working. So how do you say that this change in expression is because of NSCT and not tumor heterogeneity? You cannot say it. What is your explanation about it?
Ma'am, it will be one of the limitations in our study that we don't know how that could have happened.
Okay, so what is clinical practice at your institute? Treatment is started on core biopsy or after consideration of both the specimen?
Ma'am, they are starting it in most of the cases.
on core biopsy. But it's
Yes,
a good
ma'am.
study because whatever clones are there in residual disease, they should
Yes,
be
ma'am.
addressed. So you must understand that it is just not NSE, but clones are different, right? And what
Yes,
were the
ma'am.
challenges faced by you in post-NST specimen? What is pathological complete response? What do you mean by it?
Yes, ma'am. In most of the cases, tumor was not left to study. Residual
Yeah.
tumor was not there.
So how many such cases were there in your study?
Ma'am, I did not consider them in my study, but there were approximately I took around 52 cases in total. So I would have 60 samples I would have taken. So 8 to 10 were the ones with pathological complete response.
And what do you know about the change in receptor status in recurrences?
Ma'am, in recurrences.
What happens? ERPR positive patient presenting with liver metastasis, and do you recommend core biopsy in such metastatic foci? Is it different or is it same? They can differ. So that is the reason why on recurrences, receptor analysis must be repeated, right?
Oh, yes, ma'am.
So
Okay,
what were
ma'am.
the challenges faced by you in interpretation of ERPR on core biopsy? Do you interpret HER2/neu in invasive component, or what is the interpretation criteria for it? You said something about HER2/neu. So if only DCIS is present in core, what do you do?
Ma'am, in the invasive component, I looked for the expression of markers.
That's great. So that is one of the limitations of core biopsy, isn't it?
Yes, ma'am.
All foci may not be represented. So what are the guidelines? You said something about St. Gallen's 2013, but what about St. Gallen's 2021? Are there any newer recommendations?
Ma'am, I am not aware of that. Sorry,
Okay, that
ma'am.
was a very good topic, dear, and you presented it very well. And now I would request Dr. Sabia to add something if she is
Yes,
interested.
could you follow up any of these patients? Like, was there any change in the treatment? Or, I mean, the prognosis of these patients, like you said, that there is a change in the after adjuvant chemotherapy.
Yes,
Could
ma'am.
you follow these patients, any of them?
Ma'am, no, I did not follow them for treatment later on.
Okay, because that will tell us actually. the
Yes, ma'am.
status.
Yes, ma'am.
Okay, very well presented. Very well.
Thank you, ma'am. Thank you
Nice
so much.
presentation, Achal. It was good topic.
Thank you, ma'am.
Thank you, Dr. Achal. Thank you, Dr. Radhika ma'am, Sabia ma'am. Now proceeding on to our next presenter, and she is Dr. Himangi Ingle. So please, Dr.
Thank you,
Himangi. Thank you, Achal.
Thank you, ma'am.
Yes, ma'am. Just sharing my PPT.
Okay. Yes, yes.
Is my PPT visible, ma'am?
No, not yet. Yes, it is. No.
Yes, is it now?
Yes, 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 Doctor.
Ma'am, can I start?
Yes, yes, yes. Start. Your time
Good
starts.
afternoon, ma'am. The title of my study is Utility of Intraoperative Consultation in Central Nervous System. Lesions, comparative. Sorry, ma'am, just a minute. There is some problem with my screen. Sorry. Utility of intraoperative consultation in central nervous system lesions, a comparative study of frozen section square cytology with routine histopathology. Frozen section is one of the most challenging tasks in pathology. Intraoperative pathological diagnosis by squash cytology and frozen section plays a crucial role in patients with space-occupying lesions of CNS. It guides to plan the extent of surgery. However, the definite diagnosis relies on histopathology. The aims and objectives of my study are to compare the efficacy of squash cytology and frozen with routine histopathology, considering it as gold standard, to find out the incidence of various lesions of central nervous system, and to evaluate the reasons of discordant case results. This is a retrospective study over a span of 2 years of 160 cases, which were diagnosed and reported on frozen section, followed by routine histopathology. So samples for frozen section were received in normal saline. Squash smears and imprint smears were prepared. For frozen section, the sections were prepared in Leica cryostat and they were stained with hematoxylin and eosin. Remaining tissue was fixed in 10% formalin for routine processing. Inadequate specimens and specimens sent in formalin were excluded. In our study, males were 77 out of 160. The incidence of various lesions, the most common tumor was found to be astrocytoma with 42.5% incidence, followed by meningioma 17.5%. Lymphomas were seen and metastasis of 7.5%. Now, benign lesions like tuberculosis, cerebral abscess, and gliosis were also seen. Rare cases like AV malformation and plasma cell dyskaryosis were also seen in our study. The most common location of our tumor was supratentorial, comprising of 93 cases, followed by extraaxial and dural, which were the meningiomas. The maximum number of cases was seen in the age group of 31 to 60 years of age, and the least common was the pediatric age group. The sensitivity and specificity of frozen section in our study was 98.6 and 60% respectively. Positive predictive value was 95.5. Diagnostic accuracy was 95%. The overall concordance rate was 87.5% and discordance rate was 12.5%. The concordance and discordance rate was compared with other studies like Rosar et al., Zarbo et al., and Novis et al., which showed concordance rate of 95 and 98%. However, our study showed concordance rate of 87.5%, which was lesser. Discordant cases in our study. Cases like lymphoma and metastasis were misdiagnosed as gliomas and frozen section. Benign conditions like tuberculosis, cerebral abscess, and gliosis were misdiagnosed as glioma on frozen section. And there were 6 cases where there was difficulty in grading of tumor, low grade diagnosed as high grade and high grade diagnosed as low grade. Now let us discuss with the discordant cases. Reactive gliosis versus low grade glioma is one of the most difficult diagnostic challenges, as some degree of gliosis is always common adjacent to and associated with tumor. In such cases, sampling from the glioma area is important. Low cellularity and a low NC ratio favors a reactive gliosis. The first image is of a frozen section showing a glioma. However, on paraffin section, there was no evidence of tumor. Only gliosis was seen with astrocytes showing a mild degree of anisonucleosis. High-grade glioma versus NHL. Neoplastic lymphoid cells spread over abundant gliofibrillary background simulates a glioma. In such cases, lymphoglandular bodies in squash cytology help in lymphoma diagnosis. The first 2 images are of squash cytology and frozen section, where the neoplastic lymphoid cells against a glial fibrillary background showed it to be a glioma on frozen section. However, on paraffin section, we saw neoplastic lymphoid cells arranged around the vessels showing a perivascular pattern and also at discohesive, proving it to be a non-Hodgkin's lymphoma. Glioblastoma versus tuberculosis. Caseous necrosis of tuberculosis is misdiagnosed as necrosis of glioblastoma. Now, this is a sampling error when the only necrotic area is sampled. In such cases, thorough sampling and adequate sections is recommended. First and the second image are of squash cytology and frozen section, where we saw necrosis and glial tissue, and hence it was with some reactive astrocytes, and hence it was diagnosed as high-grade glioma. However, on paraffin section, there was no evidence of tumor. We saw only caseous necrosis, epithelioid cell granulomas, and giant cells, and it was a case of tuberculosis. Glioblastoma multiforme versus metastasis. Bizarre cells of metastatic adenocarcinoma in a necrotic background is misdiagnosed as a glioblastoma. Squash is not very helpful in metastasis as neoplastic epithelial cells resist spreading. First slide is of a frozen section where bizarre cells with pleomorphic hypochromatic nuclei and necrosis was suggestive of a glioblastoma on frozen section. However, on paraffin section, we got a beautiful image of epithelial cells arranged in glands and sheaths and nests and along with necrosis. This was a case of metastatic adenocarcinoma from lung. Oligodendroglioma versus astrocytoma. The characteristic feature of oligodendroglioma, that is a perinuclear halo fried egg appearance in paraffin section, it is a fixation artifact. It is absent in frozen section. Hence, we get this discrepancy. Problem in tumor grading, though it is not so essential to accurately grade during intraoperative diagnosis, but still we saw that some high-grade glioma were misinterpreted as low-grade because a tumor is heterogeneous and sampling only from the peritumoral area shows that a high-grade glioma is misinterpreted as a low-grade glioma. This can be avoided by taking samples from multiple areas. A low-grade glioma can be misinterpreted as high-grade as due to freezing there is enhanced anisonucleosis. Hence, it is a freezing artifact. Pylomyxoid astrocytoma versus ependymoma. The bipolar cells of astrocytoma showing angiocentric arrangement resembles a perivascular pseudorosettes of ependymoma. The causes of discrepancies in my study was sampling error, sectioning error, improper staining, freezing, crushing, pottery artifacts, and insufficient clinical and radiological information. We found out that imprint and squash cytology shows preserved cytomorphology. There is absence of freezing artifacts in cytology. It is simple, quick, and a very small tissue is required. It is superior to frozen section in gliomas, small round cell tumors, and lymphoma, where the tissue is very easy to spread. Frozen section shows a preserved tissue architecture. It is superior to cytology in meningiomas, schwannomas, and metastasis. Frozen section and cytology are complementary procedures. Both used together, the diagnostic yield is markedly increased. Hence, to conclude, frozen section is an effective tool for intraoperative consultation as found in our study with diagnostic accuracy of 95% and sensitivity of 98.6%. Avoiding technical errors in sectioning, staining, and knowledge of clinical and radiological presentation will help in making a good diagnosis. Discrepancies need to be evaluated regularly to minimize incorrect categorization. Recently, there are advanced neurosurgical techniques like stereotactic and burr-hole surgeries, which aid in sample collection from tumors at inoperable sites or tumors which requires chemotherapy, radiotherapy. These surgeries help in decreasing morbidity of prolonged surgeries. In such cases, intraoperative consultation is immensely important. However, routine paraffin section still maintains an upper edge over frozen section. These are my references. Thank you.
Thank you, Dr. Himangi. Over to Dr. Radhika ma'am and Dr. Sabia ma'am.
That was a beautiful presentation, Dr. Himangi, and I must appreciate your images. They're really nice.
Thank you, ma'am.
And I must agree that communication and clinical details, they are the main cause why we make errors. So
Yes,
do you refer to radiology and clinical details before even starting frozen section?
Yes, ma'am. Before we get a frozen section, we ask for the file of the patient having the CT images as well as the CT MRI reports, as well as we talk to the neurosurgery resident doctors or the faculty members what they are suspecting clinically, so that we get a background idea, and with the clinical, radiological, and then what we see in pathology, we give a combined diagnosis.
And do you give any specific technical tip to the present technician? Any specific tip?
Yes, ma'am. Like sometimes if the section is too thick, then we get, it is very difficult to diagnose some tumors. Hence, we ask them to give a thin section, though it is very difficult for CNS tumors, which are very soft with high water content. It is difficult to have a frozen section, but we still advise them to have a thin section and a good staining.
Right. And instead of putting tissue into the saline, have you tried putting it on a saline soaked tissue paper?
No, as of now, we have not advised or started with the saline soaked tissue paper. We receive in normal saline.
Okay. And now lymphoma. You have missed on lymphoma. So what was the radiological diagnosis in such cases where you were discrepant?
Ma'am, radiologically, a lymphoma looks like a periventricular enhancing lesion. And glioblastoma also is a rim enhancing lesion. So radiologically, they suggested to be a glioma only.
Okay.
And so there was a discrepancy found, like there was difficulty diagnosing also on the radiological front.
So can you tell us something about rapid IHC for frozen sections, IHC direct? Have you read about it?
Yes,
Rapid
ma'am.
IHC?
Yes, ma'am. I have read some art references, but we don't do it in our institute. IHC can be done in frozen section as well. But
Yes, it's not in routine practice. But if you want 3 antibodies to look for, what would be your panel in CNS intraoperative consultation?
Yes,
What
ma'am.
antibodies would you prefer?
Ma'am, for gliomas, I would prefer GFAP, glial fibrillary protein, S100. If I am suspecting a lymphoma, I would add CD1920 PAX5. So it depends on what IHC, what we are suspecting clinically and radiologically, I would suggest that way. If it is a metastatic, like it was a metastatic from lung adenocarcinoma, I would suggest a TTF or an APSIN.
Okay, so basically pan-CK, CD45, GFAP, that you would like to have to reduce the error, right?
Yes, ma'am.
Thank you. That was amazing presentation.
Thank you, ma'am. Thank you so much.
Dr. Himangi, one question from me.
Yes, ma'am.
That is any particular problems you faced while doing frozen section?
Yes, ma'am. One was sometimes there is a clinical miscommunication with the clinicians. That was the first problem. And the second problem was the freezing artifact, as I discussed. Because the CNS has a very soft tissue and it has got a lot of water content, we get freezing artifacts in many of the tissues, as well as the in the case of tuberculosis versus glioma, the only necrotic sample was area was sampled by the neurosurgeons. So the diagnosis completely came out to be different as tuberculosis, and the plan of action is different. So that was the main problem. So communicating with the clinical and radiological as well as pathology, all three are very important in frozen section.
So like ma'am said, we need to do this rapid IHC soon.
Yes, ma'am.
Yeah.
Yes, ma'am. Yes, ma'am.
Very good presentation. Excellent.
Thank you.
Nice. Thank you, Himangi.
Thank you, ma'am. Thank you.
Thank you, Dr. Himangi. Thank you, our dear judges. Now proceeding on to our next presentation, and it is by Dr. Manish Kumar. Please share your presentation.
Good afternoon to all. Shall I start?
Yes, you can start.
So the topic of my paper is clinico-radiological and histopathological study of endometrial lesions in cases of abnormal uterine bleeding. So as we all know, abnormal uterine bleeding, defined by the FIGO menstrual disorders group as bleeding from the uterine corpus that is abnormal in volume, regularity, and or timing that has been presented for the majority of the last month. And it includes the entities as menorrhagia, metrorrhagia, menometrorrhagia, polymenorrhagia, polymenorrhea, continuous vaginal bleed, and intermenstrual bleed. And according to the National Health Portal of India, AUB leads to loss of productivity and may result in surgical interventions. And it is reported to occur in 9 to 14% women with menarche and menopause. And in India, the reported prevalence of AUB is around 17.9%. And once the bleeding is defined as being abnormal, the acronym PALM coin is now being increasingly used for categorizing these causes, as P stands for polyp, adenomyosis, leiomyoma, malignancy, including the hyperplasia also, coagulopathies, ovulatory disorders, endometrial, iatrogenic, and not otherwise classified. The PALM entity are assessed visually, that is by imaging and histopath, and the coin are non-structural ones. There are various techniques to evaluate the causes of AUB, and these includes minimally invasive and invasive procedures like endometrial curettage, biopsies, ultrasonography, endometrial biopsies, hysteroscopy, and dilatation and curettage. So the aim of my study was to study the profile of abnormal uterine bleeding on histopath of endometrial lesion and its clinico-radiological association. And the objectives were to study the histopathological spectrum of various endometrial lesions in females presenting with abnormal uterine bleeding, and to find an association between the clinical features and the histopathological findings. And the third one is to determine an association with the histopathological findings with the endometrial thickness that is estimated radiologically. So this was a cross-sectional study conducted in the Department of Pathology, Government Medical College, and the associated Dr. STH Hospital, Uttarakhand, from January 2020 to September 2021. And we included all the female patients presenting with abnormal uterine bleeding, and exclusion criteria was bleeding other than endometrial causes and the pregnant females. So a total of 103 patients in age group 20 to 69 years presented with AUB. They were evaluated. However, due to COVID-19, there were a significant decrease in the number of patients that we received usually in our department. The data was collected, including the age, history, family history, live birth, hormonal exposure, and the other relevant investigations were inquired about. And the radiological data was also linked in. And especially the endometrial thickness in particular of the patients was inquired about and tabulated. And all the specimens of the endometrial curettage, biopsy, and hysterectomy received for histopathological examination during this period were processed. So what the observations were as follows. The most common age group of patients ranged from 40 years to 49 years, that is the perimenopausal age group, with a significant number of cases in the age group of 50 to 59 years. As this tabulated data denotes here that 63 cases out of 103 were from the age group of 40 to 49. And the maximum number of cases were belong to the multiparity, followed by grand multiparity. Next, the most common histopathological lesion that was reported was proliferative phase endometrium, followed by secretory phase endometrium, and including the disorder proliferative phase endometrium. The reported number of cases of endometrial carcinoma was way too low as compared to the other ones. Then we correlated the endometrial thickness basically. The range of endometrial thickness recorded in proliferative phase was 4 to 9 mm, followed by secretory phase with more than 9 to 15 mm. And all the cases of endometrial hyperplasia and carcinomas were having ET thickness of more than 15 to 20 mm and more than 20 mm respectively. Therefore, the cutoff value of 15 mm ET thickness is suggestive of clinical suspicion of atypical hyperplasia or endometrial carcinoma. The most common presenting complaint was menorrhagia, followed by postmenopausal bleed, and other important presentations were metrorrhagia, polymenorrhea, and oligomenorrhea. So the present cross-sectional study, it was conducted, as I already told, it was conducted in the Department of Pathology, GMC Haldwani, and associated STM Hospital. The tenure was January 2020 to September 2021. A total of 103 cases were included who presented with complaints of abnormal uterine bleeding. The aim of this study was to determine the clinico-radiological and histopathological profile of the endometrial lesions in females presenting with AUB in a tertiary care center of the Kumaon region. So in the present study, out of 103 cases, majority of the cases belong to the age group of 40 to 49 years, and this similar observation was made by Dorai Swami et al., Sharma et al., and Rajshri P. Ramle et al. Contrary to our results, study done by Lavanya Kumari et al. Shows maximum number of cases in the age group of 56 to 60 years, and Neha Varun et al. Showed maximum number of cases in age group 35 to 39 years. So this attribute can be explained by the fact that in our region, females are experiencing early menarche because of the stressful and exertional lifestyle, which in turn causing premature shift of cycles from ovulatory to anovulatory due to a decline in the number of ovarian follicles and the estradiol level. And the incidence of AUB between 50 to 59 years was lower as compared to 40 to 49 years because the patients were evaluated much earlier and treated appropriately, thus decreasing the incidence in later stage. Then the maximum number of cases of AUB will belong to the multiparity and grand multiparity. which is similar to the findings of Nidhimina et al. And others. This can be explained as increased parity leads to the excess and or unopposed estrogen stimulation of endometrium, causing its uncontrolled proliferation and manifestation as breakthrough bleeding. And the maximum number of cases were reported as proliferative phase endometrium, which was similar to the other studies as well, as by Sardi et al., Sharma et al., and Neha Varun et al. And with the shift in demographics in Uttarakhand towards the urbanization, there is likely an increase in estrogen-dependent pathology. The bleeding in proliferative phase may be due to anovulatory cycles, and the bleeding in secretory phase is due to the ovulatory dysfunctional uterine bleeding. The most common complaint reported was menorrhagia, which is similarity with the findings of Nayak et al., Bodhisattva Behra et al., and MB Swami et al. This attribute can be explained by the fact that patients presenting with various gynecological issues are usually being prescribed medications that have an estrogenic effect, which can induce endometrial growth and may be associated with menorrhagia and other menstrual irregularities. Also, loss of follow-up and poor compliance to the medications is way too common in our region, being a difficult geographical terrain. Due to poor health services and proper counseling, especially in the peripheries, many patients discontinue their treatment on their own, which in turn results in abnormal menstrual bleeding. And the maximum number of cases belong to the proliferative phase with an endometrial thickness of ranging 4 to 9 mm, followed by a secretory phase with ET thickness of more than 9 to 15. This observation is similar to the findings of Sardi et al. And Khanna et al. The ET thickness is highly variable. In our study, it ranges from 2.3 mm to 24.4 mm. In menstruating women, the ET thickness increases gradually and measures 10 to 12 mm by the day of ovulation and increases further up to 16 mm by the secretory phase. In our study, all the cases of hyperplasia and endometrial carcinoma were having ET thickness of more than 15 mm. So our institute caters to a significant number of female patients presenting with AUB, as it is the only government tertiary care hospital in Kumaon region. And this study has demonstrated clinico-radiological and histopathological profile of endometrial lesions in females of almost every age group complaining of AUB. Clinical findings, radiological assessment, and its histopathological evaluation provide valuable information in the workup of such patients. The present study concludes that AUB in perimenopausal and postmenopausal females is alarming and needs meticulous assessment, since it could be the only clinical symptom of endometrial carcinoma and pre-malignant entities in these patients. Also, the chances of developing AUB increase with age and parity. And proper implication of government dispensed female healthcare services and easy access to the health facilities can decrease the morbidity and mortality in cases of AUB in this region. Thank you.
Thank you, Dr. Manish. Over to our judges.
Thank you, Dr. Manish. It was very nice presentation. And I must ask you one question. What was the most challenging diagnosis you faced during endometrial biopsy interpretation? You find that diagnosis difficult. What was it?
Yes, ma'am. It was basically atypia, hyperplasia without atypia.
That was difficult, or atypical endometrial hyperplasia or endometrial intraepithelial neoplasm, that was difficult. Okay, why you found that was difficult diagnosis without atypia? What do you say in it?
In atypia without hyperplasia without atypia, actually there were
what was the difficulty? What do you see?
Ma'am, basically it was previously designated as either simple endometrial hyperplasia without atypia or complex endometrial hyperplasia without atypia. It is defined as the glandular proliferation of the endometrium resulting in shift of the gland to stroma ratio. Ma'am, it is basically there is a subjective variation in determining the shift of the gland to stroma ratio.
Okay, you come from tertiary care center, you say?
Yes, ma'am. Yes, ma'am.
Okay. So can you tell us something about effect of tamoxifen on endometrium? There must be many females on tamoxifen in cases of breast cancer, and they come for DNCs regularly.
Yes, ma'am.
So what is the effect of tamoxifen?
Ma'am, tamoxifen basically works on the ER and PR receptors.
Okay, that was nice presentation, Manish. Now over to Dr. Sabia, ma'am.
Okay. You mentioned something called disordered proliferative phase. What did you mean by that?
Disordered proliferative phase means there are presence of irregularly shaped or cystically dilated glands with relatively normal gland to stroma ratio.
So you mean endometrial hyperplasia without atypia, or how did you differentiate the two then?
Ma'am, basically
I mean, this term doesn't come in the classification. So how have you used it, and where did you put the patients? In which category?
Ma'am, we keep that in the disorder proliferative phase is a different entity that we usually give as an impression here.
So is it due to hormonal imbalance, or where do you fit this in?
Yes, ma'am, it is basically hormonal imbalance.
So, okay. Okay, good presentation.
Thank you.
Thank you, Dr. Manish and the judges. Now over to Dr. Mansi Jha.
Thank you, ma'am. Am I audible?
Yes.
Okay. My screen is visible?
Yes, yes, yes.
Okay, ma'am. I'll be starting now.
Yes.
Sorry. Good afternoon to everyone. The title for my study is a study for histopathological spectrum and Ki67 expression in neoplastic oral cavity lesions at a tertiary care center in Bhopal. The oral cavity lesions are usually common, but mostly ignored due to lack of awareness. Worldwide, oral cancer is the 6th most prevalent cancer, ranking 8th in developed countries and 3rd in developing countries. Also, it is 3rd most common in India. Most carcinomas of oral cavity are strongly associated with tobacco use, and there is a synergistic effect with alcohol. Early stage of malignancy could mimic benign lesions. Therefore,
Sorry to interrupt. Are we able to see her screen? Are we able to see
No.
Dr. Mansi's screen?
No, I'm not able to see.
Dr. Mansi, please share your screen. We are not able to see your screen.
Okay, ma'am. Ma'am, is it visible now?
Yeah,
Yes.
yeah, now we are able to.
Yes.
Sorry, ma'am. Ma'am, is it visible?
Yes.
Yeah. Good afternoon, everyone. The title for my study is a study of histopathological spectrum and Ki67 expression in neoplastic oral cavity lesions at a tertiary care hospital in Bhopal. Oral cavity lesions are usually common, but mostly ignored due to lack of awareness. Worldwide, it is 6th most common, 8th in developed countries and 3rd in developing countries. Also, it is 3rd most common in India. Most carcinomas of oral cavity are associated with tobacco use, and it has a synergistic effect with alcohol. Early stage of malignancy could mimic benign lesions. Therefore, early diagnosis for proper management and to prevent morbidity and mortality is needed. Histopathology is considered as gold standard for diagnosis and management of oral cavity lesions. The most common IHC marker for proliferation marker is Ki67 antigen, which is a nuclear protein expressed in G2 and M phases of actively dividing cells. Ki67 positive cells are often correlated with the clinical course of the disease. It provides significant information about the degree of aggressiveness and prognosis of the disease. Hence, the study is being conducted to evaluate the expression of Ki67 in neoplastic oral cavity lesions. The main aims were to study the spectrum of neoplastic oral cavity lesions, to evaluate Ki67 expression, and to study the role of predisposing factors. It was a cross-sectional observational study, including all the patients admitted under Department of Oncology from January 2020 to March 2020. A total of 24 specimens were received by the Department of Pathology, CMCH Bhopal. The received specimens were grossed according to CAP protocol, and the sections were obtained and processed as per standard histopathological protocol. These are the images showing the gross specimens: right segmental mandibulectomy and right hemimandibulectomy specimen. The inclusion criteria were that all oral cavity biopsy specimens reported as neoplastic were received by the Department of Pathology, and the exclusion criteria included tumors of larynx and pharynx and odontogenic tumors. The lesions were classified according to Broders classification into well, moderately, poorly, and anaplastic lesions as per the table. The lesions, this figure shows well differentiated squamous cell carcinoma, moderately differentiated squamous carcinoma, and poorly differentiated squamous carcinoma. The processing for immunohistochemistry was done as per the standard protocol. Sections 2 to 3 microns were taken on polyl lysine coated slides, followed by baking, deparaffinization, and hydration. Antigen retrieval was done, followed by blocking the background by blocking endogenous peroxidase and incubating with primary antibody and target binders. Further, secondary antibody was added and chromosome DAB was added. The final step was counter staining with Harris hematoxylin for 2 minutes. Positive control was taken to be anaplastic thyroid carcinoma, and negative control by omission of the primary antibody. All slides were examined and scored. ISC assessment was done for 2 parameters: index of positivity and intensity of staining. Index of positivity was calculated, which was represented as the percentage of labeled cells in 1000 counted cells in 40x microscopic field. Score 0 was given to less than 10% of labeled cells, score 1 to 10 to 50% of labeled cells, and score 2 to more than 50% of labeled cells. And intensity of staining was scored as score 0 for weak intensity, score 1 for moderate intensity, and score 2 for strong intensity. These are the images showing the positive control and the negative control. As we can see, the positive control, almost all the cells have taken the stain, and in negative control, as the primary antibody was omitted, none of the cells have taken the stain. This is the figure 6 showing well-differentiated squamous cell carcinoma, for which the index of positivity score is 10 to 50% of labeled cells, that is score 1, and the intensity score is also 1, moderate intensity. The next image shows moderately differentiated squamous cell carcinoma. The index of positivity is 10 to 50%, reflecting score 1, and strong intensity, reflecting score 2. This figure shows poorly differentiated squamous cell carcinoma. The index of positivity is more than 50% of cells scored as score 2, and strong intensity, again score 2 for intensity. Data collection analysis was done in Excel sheet version 2016 and SPSS. The results were calculated and displayed in the form of percentages and normal Gaussian distribution. Other appropriate state tests were applied. The results were as follows. Most of the patients belong to age 31 to 40 and 41 to 50. Most of the patients, that is, were male, 70.8% of the patients. The most common site of involvement was buccal mucosa, followed by tongue. Most of the lesions showed association with tobacco and bidi smoking. This was the distribution on the type of lesion, which was 75% malignant, 16.7% pre-malignant, and 8.3% benign lesions. Most of the lesions were ulceroproliferative growth, that is comprising 9 lesions and 37.5%. Most of the lesions were moderately differentiated squamous cell carcinoma, followed by poorly differentiated keratinizing squamous cell carcinoma. This is
1 minute to go, Dr. Mansi, and please continue. 1 minute to go, please continue.
Yes, ma'am. The distribution of study participants was as follows. Score 2 was 70.8% for intensity, and the p-value was 0.029, which was significant. Distribution for index of positivity was 62.5% for score 2, and the p-value was found to be less than 0.001, which was highly significant. Similar designs in a study by Priyanka Yadav et al., significantly higher proportion of cases displayed positive immunoexpression. Ki-67 intensity score followed similar trend with a strong intensity of staining, which is significantly showing higher number of malignant cases than pre-malignant cases and benign cases. A study by L.P. Dragomir et al. Revealed carcinomas were diagnosed in patients 40 to 60 years, males with chronic exposure to tobacco and alcohol, especially located on lips. Also, the study showed association to the decrease of degree of tumoral differentiation, that is more towards poorly differentiated. Ki-67 labeling index was observed to be significantly correlated with the increasing histological grades of oral squamous cell carcinoma in the study by Agrawal et al. Out of 50 cases, maximum belonged to the age 41 to 50, and buccal mucosa was and tongue were the most common sites. Veena Maheshwari et al. Study showed Ki-67 expression of dysplasia and for carcinomas, the difference being statistically significant, and the smoking and tobacco chewing was associated. Premlata BR showed a generally increasing trend in mean Ki-67 index with increasing Broders grade. There was significant difference between the three groups, and the p-value was significant. Also, male to female ratio was found consistent with a study conducted by Singh MP et al. So what we concluded was that Ki-67 expression increased in terms of intensity and index of positivity with increasing histological grade, showing a statistically significant trend, thus concordant with the results obtained by other similar studies. The Ki-67 expression would be useful as a prognostic indicator in detecting clinical outcome of different histological grades of oral cavity lesion. Also, it is a good IHC marker in determining the aggressiveness of the tumor. It is believed that the proliferation index of a lesion indicates its future behavior and pattern. Hence, our study trial has greater statistical significance in early detection and effective management of oral cavity lesions. Thank you.
Thank you, Dr. Mansi. Over to our judges.
Thank you, dear Mansi. It was very nice presentation and interesting topic. I have two questions for you regarding subjectivity of Ki-67 interpretation.
Yes, ma'am.
So what was your method of counting Ki-67?
Ma'am, for
global or hotspot, what was it?
Yes, ma'am.
Method of counting Ki-67?
Ma'am, we counted 1,000 cells approximately in the low power field, 40x. And
in biopsy specimen?
Yes, ma'am.
Okay.
And out of it, we estimated the percentage of cells positive in up to the fields for which 1,000 cells were counted.
Could you come across standardized cutoffs for differentiation between leukoplakia, dysplasia, and early invasive cancers? You said it can be used. Could you come across cutoffs?
Ma'am, cutoffs were not exactly, but yeah, we could say that if we find more proliferation in dysplastic lesions or leukoplakia, we can go for early management for the patient.
Okay, and any comment on role of digital pathology in Ki-67 indexing?
Sorry, ma'am, I'm not exactly aware of it.
Okay, that was nice presentation. Over to Dr. Sabia.
Dr. Mansi, I have one question.
Yes,
what was the role of Ki-67 in the verrucous lesions, verrucous carcinoma? That is a problem on H&E sections. So
Ma'am.
where did you fit that?
Ma'am,
Or was there any change in Ki-67 in the in situ lesions and verrucous lesions? Or was it similar to early squamous cell carcinoma?
Ma'am, verrucous was basically fitted in well-differentiated squamous cell category. The results were similar to well-differentiated.
Yeah, did you mention that?
Ma'am, I don't know about the line, but our results were similar.
So verrucous carcinomas are termed as, according to Ki-67, they are same as early squamous cell carcinoma.
Yes, ma'am, well-differentiated early squamous cell carcinoma.
Okay, very well present.
Thank you so much, ma'am.
Thank you. Now our next presenter is Dr. Medha Tiwari. Please share your presentation, Dr. Medha. Are you there, Dr. Medha?
Dr. Medha is not, she has not logged in. I'll just try to connect with her.
Okay, shall we proceed with Dr. Supriya?
Yes, ma'am.
Are you there? Okay, we will take her later on. Dr. Supriya, are you there? Please share your presentation. And participants, please stick to your time of 7 minutes. Okay, proceed. Yes, Dr. Supriya.
Ma'am, just give me 1 minute.
Okay.
Itu. Wait.
Dr. Supriya, please share.
Yes, ma'am.
Please share your presentation.
Yes, ma'am. Ma'am, I'm sharing. Just give me a minute. Ma'am, am I visible?
Your presentation is not visible. Just one slide I can see. ASUS. SS. Presentation you have to share.
Ma'am, I am visible now?
No.
Screen share. Share. Wait. No visible. Ma'am, I am visible. Am I visible?
No, you are not visible, neither the screen. Now. We got it. Okay. Start. Yes, it is visible. Please start, Dr. Supriya.
Good afternoon, everyone. Myself, Dr. Supriya Ware from GMC Nagpur. I'm presenting paper on post-COVID mucormycosis, a cross-sectional study at designated COVID hospital. A novel coronavirus is a highly transmissible coronavirus which emerged in 2019. In world total 442 millions and India 42.9 million cases of COVID-19 disease reported till date. Second wave was associated with dreaded complication of post-COVID mucormycosis with 14,872 cases as of May 28 of 2021 in India. First case of post-COVID mucormycosis was noted in March 2021. Mucormycosis is an opportunistic, uncommon but serious infection causing destructive disease. It is commonly seen in diabetic patient, immunocompromised patient, in those having malignancy and prolonged neutropenia. Aspergillosis and Candida co-infection also found in several cases of COVID-19 patients. Various theories were proposed to support the sudden rise in increased cases of post-COVID mucormycosis as an ideal environment of low oxygen, high glucose level due to diabetes, new onset hyperglycemia, steroid-induced hyperglycemia, acidic medium due to metabolic acidosis or diabetic ketoacidosis, and high iron level due to increased ferritin level, decreased phagocytic activity of WPCs due to immunosuppression, and prolonged hospitalization. Aim and objectives of the study to carry out preliminary observational study of post-COVID mucormycosis to find out mixed infection associated with mucormycosis and to know association of post-COVID mucormycosis with risk factors. This is retrospective cross-sectional study carried out during April 2021 to July 2021, including 132 cases, and cases include all clinically suspected cases of post-COVID mucormycosis. All RT-PCR positive patients clinically suspected for mucormycosis infection who underwent biopsies were included in the study, and those clinically suspected cases of mucormycosis in which mucor was not detected on microscopy were excluded from the study. We analyzed COVID status, clinical feature, comorbidities, laboratory investigation, also radiological and surgical, radiological investigation, surgical procedures, and histopathological findings. On microscopy, we observed necroinflammatory reaction, giant cell reaction, granulation tissue, and other additional findings such as vascular invasion, neural invasion, and mixed infection were also noted. In 109 out of 132 clinically suspected cases, we confirmed mucor on histopath examination. Most common age group was 5th decade with mean age 43 years and male to female ratio was 1.7. 95% patients were hospitalized during COVID illness. Clinical presentations were headache, fever, cough, facial swelling, breathlessness, pain, visual complaints, like diminution of and blurring of vision and watering of eyes. In our study, 28.4% patients were having history of previous diabetes mellitus and 11% presented with history of hypertension. Systemic corticosteroid were administered in 60% of the patients and supplemental oxygen was provided or given to 90% of the patients. Histopathology showed typical morphological features of mucor, such as broad branching acceptive fungi. Angioinvasion, perineural invasion also noted, and other co-infections with other fungi such as Candida, Aspergillus, and Actinomyces were also observed in this study. Table number was showing extent of involvement based on radiological investigations such as CT and MRI. Sinus involvement was observed in 95% of the patients, and other were orbit or CNS involvement. And among sinuses, maxillary sinus was the most common sinus affected, followed by ethmoid sinus. Then surgical intervention taken, where debridement surgeries, maxillectomy, that may be partial or complete maxillectomy surgery, functional endoscopic sinus surgery, debridement and maxillectomy together, or debridement and orbital exenteration together. Among this, debridement was most common, that was in 76% of the patients. And histopathological findings, necroinflammatory reaction was most commonly observed almost among all patients, that accounting for 78.8% of the patients, followed by giant cell reaction in 19.26% of the patient. We also got the other interesting findings such as other mucor associated with other fungal species such as Aspergillus candida and actinomycetes, etc. And few cases of the angio-invasion, neuro-invasion were also observed, with one case of intraorbital spread noted. Going with gross findings, in most of the patients we received the specimen as multiple gray brown tissue pieces. Picture second shows the total eyeball exenteration specimen. Coming to the microscopic findings on HA and past staining, we can see here colonies of mucor with hyphae, broad branching aseptic hyphae we can see. In few of the cases we got mucorconidia, and other cases we got mucosporangium also. Necroinflammatory and giant cell reaction also noted. Here we can see giant cell and inflammatory infiltrate. Then optic nerve invasion, neural invasion, bony invasion we also observed, and actinomyces. Here we can see past stain and actinomycetes colonies. Then significant association observed in post-COVID mucormycosis and history of diabetes mellitus and hypertension. Post-COVID mucormycosis was most commonly seen in patients on steroid therapy and receiving supplemental oxygen. Radiologically, maxillary sinus involvement was most common, followed by ethmoid sinus. On histopathology, majority of the cases showed inflammatory and reactions and necrosis, and few of the showed giant cell reaction. We also observed angio-invasion, neuro-invasion, and also in a single case, intraorbital spread of mucor was there. In present study, we observed mucor with other associated infections like Candida, Aspergillus, and actinomyces.
1 minute left. Please continue. 1 minute left. Please continue.
This table shows comparison of our study with other studies. Coming to the conclusion, there is a sudden increase in mucormycosis in post-COVID patients after second wave. Possible causes may be due to steroid immunocompromised stage, diabetes mellitus, unnecessary O2 therapy. So steroid, O2 and oxygen should be used judiciously. Blood glucose level should be monitored regularly. Early diagnosis is warranted for definitive treatment and to avoid lethal complication and death of the patients. Patients with history of COVID-19 disease with risk factor should be carefully observed for presenting features of mucormycosis. These are the references.
Thank you, doctor. Over to our judges.
Very nice presentation, Supriya. It was most relevant talk, and I must congratulate you for the numbers and beautiful images. I have one question for you. What was the mortality rate in your study? Do you have follow-up of the patients?
No, ma'am. For mortality rate, we didn't analyze. It was retrospective study.
Okay, okay. Nice presentation. Over to Sabia.
Very nice pictures you showed, Supriya, and very nice presentation. There is one question from me that was there any change in the prognosis with multiple fungal infections in the patients? You have given one category like that. With mucormycosis, you had other fungi.
Ma'am. Yes, ma'am. If there is multiple infection present in the patient at the same time, prognosis will be poor for that patient.
So, but you said you didn't follow up the patient?
Yes, ma'am. I didn't follow. It was a retrospective study, so it was.
So you couldn't find out the prognosis.
Yeah, ma'am.
Okay. Good presentation.
Thank you, ma'am.
Thank you, Dr. Supriya and judges. Now over to Dr. Suresh Kaundiyal. Sorry. Dr. Suresh, please.
Dr. Suresh doesn't seem to have logged in, Huma ma'am. I'll just check and we can, or else we can go ahead
now
with the
over
next.
to
Yes, ma'am, I am.
Sanketa. Are you there, Dr. Suresh?
Yes, ma'am.
Should we wait?
Hello.
Yeah,
Okay. Are you there? So please share your presentation.
Hello.
Yes, Dr. Surya.
Am I audible?
Yes, you are audible. Please start.
Good afternoon, everyone. My topic for poster is the study of grade of tumor budding and its association with clinical pathologic parameters in breast carcinoma. Coming introduction, breast cancer is the second most common cancer in the world and the most frequent cancer in females, with estimated 2.8 million new cases in 2018. It constitutes 11.6% of all cancers. Incidence rate is 25.1% with age standardization rate of 46.3 per 1 lakh women and 5-year prevalence is 36.3%. In India, the incidence of breast cancer in females is 27.7% with age standard to 24.7% per 1 lakh females and 5-year prevalence is 32.2%. Coming to topic, tumor budding, which represents the single or a small cluster of tumor cells detached from the main tumor mass and present at the invasive front of tumor. It's a recent phenomenon which is being studied in various cancers, and I am studied in this breast cancer. It's a pathological event in which a small group of undifferentiated malignant cells, usually maximum up to 5 cells, detached from the main tumor mass, margin of the main tumor bulk. It is the first step of metastasis and studied in several cancers, including head and neck, colorectal, esophagus, breast, lung, and gastric carcinoma. Aims and objective are to evaluate the tumor budding in breast carcinoma and to find its association of tumor budding with clinical pathological parameters in breast carcinoma. All cases of the breast cancer are diagnosed in the pathology department of Himalayan Institute of Medical Science and immunohistochemistry of the same institute over a period of 1 year. Tumor budding was analyzed in histopathological section and immunohistochemistry of the breast carcinoma cases. Tumor budding was graded according to the number of tumor buds. Low grade when less than 20 tumor buds per 10 high power field. High grade when more than 20 tumor buds per 10 high power field. And this confirmation was done by ISC PANS cytocreatine. Tumor budding was statically analyzed for histomorphological, clinicopathological features, grading, and TNM staging. Results: the study includes 50 cases, all were females, 84% cases are housewives, 72% are vegetarians, and 58% cases were of middle socioeconomic status. 4% cases having positive family history. Right breast was most commonly involved. Out of 50 cases, 98% were multiparous. 44% cases were present in upper and outer quadrant. According to the Virat's 4C, the most common maximum cases, followed by Virat's 5. Tumor grading grade 2 by present in 72% cases, and TNM staging T2 N0MX is the maximum in 22% cases. Maximum number of cases, 48% were a luminal B type of breast cancer. This is the cases that educated education of the cases. Maximum cases were educated 26% up to the primary level. Low grade tumor budding was studied in 66% cases. High grade tumor budding was maximum in 31 to 40 year of age group. High grade tumor budding was maximum on right side of breast, that is 57.1%. 60% of tumors show high grade tumor budding where size 2 to 5 centimeter. 73.5% cases have high tumor budding with grade 2 breast cancer. 82.9% cases with high grade tumor budding observed in lymphovascular invasion. 77.4% cases showing high grade tumor budding had a lymph node involvement. 97% cases having infiltrated ductal carcinoma, and this is a significant study. Statistically significant higher infiltration in ductal carcinoma compared to the other carcinoma. The p-value is 0.03. High grade tumor budding was maximum 57.5% and it's mostly T2 stage. 68% cases show tumor budding are ER negative, PR negative, and HER2 negative. High tumor budding observed in 91.4% cases of and high castration probability index. Triple negative luminal B was most common cancer in the low grade, while luminal B also have a high grade tumor budding in 54.5% cases. Low grade tumor budding was 100% alive. This is the photograph, first one showing H&E section of the low grade tumor budding in grade 2 infiltrated ductal carcinoma, 10x and 40x. This is the immunohistochemistry pan-CK in low power and high power of low grade tumor in the infiltrated ductal carcinoma. This is the H&E section, high grade tumor budding in low power and high power. This is the ISC for same low, showing the high grade tumor budding in low power and high power. This is the left side is the histosection of the lobular carcinoma, right side is the mucinous carcinoma in HND section. And coming to the ISC, this is the lobular carcinoma and mucinous carcinoma, showing the tumor budding. This is the lymphovascular invasion, HND section and immunosis. Coming discussion. The previous study have shown association of breast cancer with tumor size and growth pattern. In our study, the result was 60% cases to tumor size 2 to 5 centimeter, and mean value was 4.37 plus minus 2.1 centimeter. The Bloom research study system was introduced to grade the breast carcinoma, and the Nottingham modification of modified Bloom Richardson system is the most commonly followed. In our study, Nottingham 72% cases were of grade 2, followed by 20% cases of grade 3. LBI is a marker for poor prognosis. In our study, lymphoblastom was present in 78% cases, and high grade tumor budding observed in with lymphoblasticuli having 82.9% cases. In most of the studies pertaining to the distribution of the breast cancer, luminal A and triple negative type, in our study, 48% cases were luminal B type. This is the overall study, but in Asian population, we are considering with the VAPM B and T all. In a study, it was shown that high grade tumor budding, as well as tumor size, nodal status, and presence of lymphoblastic were the impedant associated with overall survival. In our study, high grade tumor budding was observed in 31 to 40 age group, and it was associated with lymphoblastic embolism and PNI in 82.9% and 14% respectively. It has been studied previously that high grade tumor budding had a worse survival.
1 minute left, please continue. 1 minute left, please continue.
This is continuous with our study, where 100% cases alive with low grade tumor budding in high grade tumor budding in 94.4% cases. Limitation, further study with larger number of cases with extended duration may be needed to associate the tumor budding and prognosis in the breast carcinoma cases. Conclusion, the study concludes that breast cancer was more common in the female in the 4th to 5th year of life. In the middle status, breast cancer was more common in multiparous female, and the size ranging from 2 to 5 centimeter, and in pattern of growth. The most common breast carcinoma was RBS scoring was grade 2. Luminal B was the most common molecular classification of breast cancer, followed by triple negative and HER2 negative. The maximum tumor size were number of cases were T2 angiomas stage, a survival more than 6 month diagnosis. High grade tumor budding was associated with 97% of IDC and grade 2 breast cancer. Statistically, high grade tumor budding was not associated with lymph node involvement, lymphoblastic emboli, or pleural invasion. High grade tumor budding was not associated with the molecular type, TNM staging, or survival of the cases. Thank you.
What two judges?
Nice presentation, Dr. Suresh, and it's an interesting topic. Now, according to you, it's a poor prognostic indicator. So can you just tell me something about epithelial mesenchymal transformation?
Yes, ma'am.
Why these birds are more aggressive? Just a word on it.
Ma'am, and then principle these mesenchymal, like certain genes are there, snail gene, FOX2 gene, expression is, this gene expression is decreased when they convert to epithelial to mesenchymal. The property retain when they metastasize from one side to other side, they again express this gene and convert their property to mesenchymal type according to their site. So this is the still I'm huge topic, EMT transmission, but genes are involved like E-cadherin in the starting. Later is the snail gene, FOX1, FOX2, like these genes.
And have you started reporting it regularly in your histopathology reports at your institute, tumor budding in breast cancer?
No, ma'am. They just studied.
Just for study purpose. Okay.
Yes, ma'am. This study tumor.
Okay, okay. So no clinical impact yet.
Yes, ma'am. Tumor budding was more studied in colorectal and other cancer. Breast carcinoma is not studied. So we have started this trying to correlate with this parameter. There is any benefits there to correlate with like any early stage of staging and to give the better to the patients.
Yes, yes. Thank you. Nice topic. Keep it up. Over to Dr. Sabia, please.
Nice topic. And nice presentation. That's all.
Thank you.
Next presenter, thank you, Dr. Suresh. Next presenter is Dr. Divya Macheva. Please share your screen. Dr. Divya.
Yes, ma'am.
Yes, yes.
Is my screen visible to all?
Yes, yes. Please start.
Good afternoon, everyone. I am Dr. Divya Machivar, and the topic study of malignant lesions of breast with histopathology and molecular subtype correlation. So, as we all know that breast cancer has become the most common cancer diagnosed in women, and it is the second leading cause of cancer death among them. So, this was the reason that intrigued me to pick up this topic as my paper presentation. And there are many variable histologic types. Many variables such as the histologic type, tumor grade, size, nodal involvement, and the status of the hormone receptors plays a significant role in determining the management as well as the prognosis of breast cancer. So when we talk about the histologic subtype, then around approximately 80% of the breast cancer are designated as infiltrating duct carcinoma, not otherwise specified, but the behavior is not uniform. So this is when the molecular subclassification of the breast cancer comes into play, and it is more influential than the histopathology as a predictive factor for breast carcinoma. So in this study, we have correlated the histopathological findings of the breast carcinoma cases with the molecular subtypes, which will ultimately help the physician in directing the treatment and even the prognosis of the breast cancer. So the objective was to explore the correlation of the breast carcinoma with the molecular subtype and to grade and stage the tumors for therapeutic and prognostic purposes. Now the materials and method that we've used here was we have included around 50 modified radical mastectomy specimens in the study, and they were subjected for routine histopathological examination and immunohistochemical analysis. The study was conducted over a period of 24 months. And the exclusion criteria was the biopsy specimens were males were excluded, and the equivocal cases for HER2 expression were excluded. And then chi-square test was done to know whether there is any correlation between the histopathological. So the observational results starting with the distribution of the cases according to the age group and the lethality of the tumor. So we could find that the most common age group in our study was the age group which was women who were above 50 years of age. And if I talk about the lethality, and the left breast was marginally more affected than the right side. So around more than 50 were above the age of 50 years, and 52% were in the left side of the breast. Now talking about the distribution of cases according to the size and the histologic type of the tumor. So of the 50 patients, one patient did not show any tumor evidence and was reported as occult primary breast carcinoma. And among the rest 49 patients, the most common tumor size was between the range of 2 to 5 centimeter. And hence it was considered the most common tumor size, that was T2. And talking about the microscopic type, so we have got mucinous carcinoma, neuroendocrine carcinoma, solid papillary, lobular, and tubiform carcinoma, along with breast carcinoma of no special type. So, but the majority of it was no special type, was designated as no special type, followed by lobular and mucinous, and then the other carcinomas. Now talking about the location and the grade of the tumor. So basically the quadrant which was involved and the grade of the tumor showed a significant association with the molecular subtype of the breast carcinoma. So this I'll be telling you in detail. So the most common quadrant that was involved in our study was the upper outer quadrant, and the least common quadrant was the lower inner quadrant. And talking about the tumor grade, so the most common tumor grade was the moderately differentiated tumor grade, that was grade 2. And the least common was the well-differentiated one. That was accounting for only 7% of the cases. Now, talking about the correlation, so when we applied chi-square test to it was found that the p-value was less than 0.05, and hence it showed a significant association with the molecular subtype. And the most striking finding was this, that the tumors located in the central quadrant were falling in the category of luminal A or luminal B. And under luminal B also, it was luminal B HER2 negative molecular subtype. And none of them were found to be triple negative or HER2 positive. Hence, on the basis of this observation, we could state that the tumors in the central quadrant had a better prognosis. Secondly, the tumors in the lower inner quadrant were mostly HER2 positive or triple negative, and there were only a small portion were falling into the category of luminal. So that's why it can be considered that the tumors in the lower inner quadrant had poor prognosis. Now talking about the correlation of the tumor with its grade, and the correlation of the tumor grade with its molecular subtype. So all the well-differentiated and the grade 1 tumors were mostly luminal A-like or luminal B-like molecular subtype, whereas the moderately differentiated grade 2 tumors were of all the 5 molecular subtype, and under poorly differentiated, we hardly found any luminal A category. So the more the grade was, the poorer was the prognosis, and there were no luminal A category in poorly differentiated grade 3 tumors. And the p-value found for this was 0.009. That was less than 0.05. Now, these are the two microscopic images of the first image is showing you the infiltrating duct carcinoma, no special type. The second one is showing you a jigsaw puzzle-like pattern in case of a solid papillary carcinoma with neuroendocrine differentiation. The third image is of a lobular carcinoma, which is showing you a typical Indian file pattern that is usually seen. Figure 4 is showing you tumor cells floating in pools of mucin with eccentrically placed nuclei. That is seen in usual mucinous carcinoma. The fifth image is showing you the cribriform appearance. That is, you can see the well-defined spaces formed by the arches of the tumor cells. And on the sixth image, we can see that 8x8 complete nuclear positivity. This is how a nuclear positivity in an ER and PR stain sections will look like.
1 minute left, please continue.
Yes, ma'am. From this in figure 7.1, we can see the HER2 positivity, the low PAR and high PAR. And this basically, this was the Ki67 index. So the first one is showing you less than 14% proliferative index, and the second one is showing you more than 14%, because this was the criteria used to differentiate luminal A from the luminal B category. So in our study, it was found that most of our cases were detected in women who were more than 50 years of age, which was in concordance with many of these studies. And the second thing that we found was that the left breast was marginally more affected, which was probably owing to the fact that it has more bulkier and has larger volume of breast tissue comparative to the right breast. Now, the third thing that we found out that it is the present study, only 8% of the patient had a tumor size less than 2 centimeters, whereas in studies which happened in US or Poland, it was 58.4 and 51.9%. which actually indicated that there was a delay in the diagnosis in the Indian population, which may be due to the lack of awareness about breast cancer, or as well as the absence of comprehensive screening programs for the same. And talking about the microscopic type, so it was in concordance with many studies like the Saxena et al. The NST type was the most common one, followed by the lobular and mucinous carcinoma. Now, this was the grading comparative incidence of frequency of grade of the tumor. So it was in concordance with all these studies like your Subachela, Ambroise et al., Githamla, and Adair. But the Gold et al. Was the only study in which it was not in concordance, where the grade 3 tumor was more common. And in our case, the moderately differentiated grade 2 tumor was more. So even as I have already told.
Dr. Divya, please, can you hurry up?
Yes, ma'am. So, ma'am, there was a positive association with the quadrant and it was in concordance with many of these studies. So only the quadrant thing that I would just like to highlight is this, that the upper outer quadrant, the association that we have seen was this, that in our study, it was observed that the central quadrant was categorized as luminal subtypes. But, and this type, these findings were in concordance with studies like Roman et al. And Suint et al. Out of these 3 studies, only Lim et al. Has given the molecular association of lower inner quadrant triple negative and HER2 positive, and hence a poor prognosis, whereas the other studies was done on the basis of multiple parameter and follow-up and not on the basis of molecular subtype. So, ma'am, the conclusion was only this, that on the basis of the above conclusion that I've already stated before, it could be stated that the histopathological grading put together with the molecular subtypes offers an excellent method of correlation of survival rate and response to hormonal therapy in case of breast carcinomas. These were my references. Thank you.
Over to judges.
Thank you, dear. It was a nice presentation. I just have one question for you. What is ER low positive? And did you report ERPR at your institute, or is what outsourced?
Ma'am, we have reported ERPR at our institute only.
Okay. So What is ER low category?
Ma'am,
Positive.
Ma'am, basically we have followed audit score for scoring or giving the positivity or the negativity of the AR and PR. And ma'am, whenever the score was 0 and 2, it was considered as negative, and whenever it was of 3 to 8, it was considered positive. So usually if it is 3 or something, it's considered as low positive.
Now, even if you follow alert scoring, you have to follow the guidelines of ASCO-CAP for biomarker reporting, isn't it?
Yes, ma'am.
So you just check those guidelines, and
Yes, ma'am.
KI67, you have taken cutoff as 14%?
Yes, ma'am.
Okay, so there are references now and they are taking 20% as cutoff, and you have to establish your own cutoff in your laboratory.
Okay, ma'am. Actually,
molecular subtypes, how do you write it? Just tell me example of luminal B type.
Okay, ma'am. So, ma'am, according to the latest WHO 2019, ma'am, the main 4 molecular subtypes are your luminal A, luminal B, HER2 overexpressed, and your triple negative. So, under luminal A category, ma'am, the ER will be positive, PR will be positive, HER2 will be negative, and Ki67 will be less than 14%. Talking about luminal B, it is again subdivided as luminal B HER2 negative and luminal B HER2 positive. Under luminal B HER2 negative, it will be ER positive and PR can be variable, and HER2 will be negative, and Ki67 will be on the higher side. Whereas luminal B HER2 positive, it will be ER positive, PR is again variable in this case, and HER2 will be positive, and Ki67 will be on the higher side. Talking about HER2 positive cancers, molecular subtype. So in that, ER and PR will be negative and HER2 will be only positive in that case. And in triple negative, all the 3 markers will be negative. That is your ER, PR, and HER2.
And did you get cases like ER negative and PR positive?
Yes, ma'am. But some of those cases where I found, I've excluded those cases from my studies because we thought that could be maybe because of some scaling problem or some fixing issues. But again, this thing was the same tissue was taken for ER as well as PR. So we couldn't come to a conclusion why that thing.
So you got cases like that, ER negative, PR positive, which you discarded.
Yes,
so what is above molecular subtyping by immunohistochemistry? A word about gene expression profiling. Will you be able to say something about GEP?
Ma'am, we are doing like oncotype DX and like
that's different. Yeah, okay, that was nice presentation. Thank you so much.
Thank you, ma'am.
Okay, just one question, Dr. Divya.
Yes, ma'am.
What was your take on the variants of breast carcinoma? You showed so many variants like those.
Yes, ma'am.
Neuroendocrine expression in that papillary carcinoma and all that. So yes, how were your markers related with that? IHC markers and the grade of the tumor.
Yes, ma'am. So, ma'am, if we talk about lobular carcinoma, if we talk about solid papillary carcinoma, if we talk about mucinous carcinoma and cribriform carcinoma, so all of these tumors lie in the category of luminal A, except one pleomorphic lobular carcinoma was also present, which was of higher grade, which was triple negative rather than luminal A category. But otherwise, all these carcinomas were falling under the category of luminal A, that is low grade.
So the majority of the variants you say are luminal A carcinoma.
Yes, ma'am. Like the one which I have found in my studies, they were of luminal A category, like your mucinous. Only pleomorphic lobular carcinoma, that which I found was triple negative. Other than that, all of them were luminal A.
Okay. Yes. Very good presentation, and your pictures were really nice.
Thank you, ma'am.
Thank you. Our last presenter is Dr. Akshay Agrawal. Please share your screen. Dr. Akshay.
Yes. Thanks. Yes, ma'am. Is my screen visible?
Yes. Yes. Start, please.
Yeah. So good afternoon, teachers. My name is Dr. Akshay Agrawal, and I'm from Dr. D.Y. Patil School of Medicine, Navi Mumbai, and I'll be presenting the paper on the histopathological study of upper gastrointestinal infections. So coming to the introduction, the upper GI disorders are one of the most commonly encountered problems with high degree of morbidity and mortality. The lesions may occur due to various infections, inflammatory disorders, vascular, fungal conditions, toxic and chemical reactions. And since my study was restricted to the upper GI, which we have included the esophagus and stomach up to second part of the duodenum, the upper GI lesion may range from gastritis to Barrett's esophagus, dysplasia, peptic ulcer, GRD, gastroesophageal reflux disease, the gastric and the esophageal carcinoma, and the perianal. The upper GI endoscopy in combination with biopsy play an important role in early diagnosis of GI neoplasm and lesions, and use of flexible endoscopes have made diagnosis simple, safe, and well-tolerated procedure. And tissue specimens can be removed under direct vision using the biopsy forceps and sent for histopathological evaluation. The biopsy specimens are used to confirm endoscopic diagnosis in cases of suspected malignancy, or to rule out any endoscopically benign appearing lesions. So endoscopic screening may also detect gastric mucosa lesions in early stages like atrophy, intestinal metaplasia, and dysplasia, so as to prevent progression of lesions to invasive cancer. So my objectives in the study was to determine the histopathological lesions of upper gastrointestinal tract with overall frequency, age, and sex distribution, to study varied spectrum of histopathological lesions of both non-neoplastic and neoplastic in patients undergoing upper GI biopsy, and to establish the endoscopic biopsy as an effective tool in proper diagnosis and its correlation with my histopathological diagnosis. So a prospective upper gastrointestinal lesions of 151 cases were studied over a period of 2 years. So my inclusion criteria included, as I said, the endoscopic biopsies of the upper GI tract up till the second part of the duodenum, along with the resected specimens. And exclusion criteria were the duodenal biopsies below the second part and all lesions of mouth. Apart from endoscopy, other modalities of investigations were also being done, like ultrasonography and the PET scan for further evaluation, and the demographic details, the clinical history, physical examination, everything of the patient was collected. And the biopsy specimen, which came in 10% formalin, were taken on the filter paper and processed manually, and further processed for histopathologically sectioning. And the gross findings were noted and the sections taken. And of course, tissue processing, then the cutting and the staining was done. And GIMSA was done for H. pylori, and special stains like PAS was also used, and GMS, which is the Gomery methane silveramine stain, was used for the functions. So sharing the age-wise distribution of the patients, we of course noticed that more people were in the bracket of greater than 60 years, which included a total of 51 patients. And the site of
there was so less time and there's so much to see. They were like, this is your side.
So site of GI lesion was stomach, which included a total of 106 cases. And on histopathological spectrum of lesions in esophagus, we noticed squamous cell carcinoma in 43.3% of the patients, and 13.3% were esophagitis. So I'll be discussing the lesions of esophagus and the lesions of stomach in the category. So in the lesions of stomach, we saw the chronic gastritis, the non-neoplastic were more, which was around 56.6%. And so, of course, the subcategory, the H. pylori and the autoimmune, it comes under chronic gastritis. So we notice H. pylori as a part of chronic gastritis having the most percentage with around 24.5%. So this is a lesion of esophagitis where I see a lot of chronic inflammation, and esophageal candidiasis where I could see the fungal hyphae. And another picture of a very differentiated squamous cell carcinoma where we can very well appreciate the keratin pearls, and a beautiful signet ring adenocarcinoma where we can see the nucleus pushed to the periphery, which is eccentric and vacuolated. And the chronic gastritis, again seeing chronic inflammation, and chronic active gastritis where we can see some of the neutrophils inside this. And this is the special stain, which is the GIMSA stain was done to highlight the chronic gastritis, and another GIMSA stain for the Helicobacter pylori, which I could see the. So coming to the discussion part, upper GI tract disorders were one of the most commonly encountered problems in the clinical practice. And carcinoma stomach is the second most cancer, and the esophagus is the 6th leading cause of death. So early detection of malignancy helps greatly improving the survival rate of patients. And upper GI endoscopy is regarded as still the most sensitive and the specific method of early detection of cancers. So endoscopic biopsy examination followed by the histological assessment as the gold standard. So it is not only used to diagnose the malignant and inflammatory lesions, but also monitoring the course, extent of the disease, and the response of the therapy. So this is reflected by a rising trend in, we can see as pathologists, we are getting more mucosal biopsies from the upper GI these days. And the present study was taken to understand the non-neoplastic and the neoplastic. So out of 151 cases, we saw 30 cases were from the esophagus. And among the esophagus, both the non-neoplastic pathologies and 50% were malignant in my case. And a rising pattern, which I saw in my study, was in the esophageal malignancy. More were observed in females than earlier reporting showing male predominance because of high incidence of malignancy. Females may be due to the changing socioeconomic habits these days. And the overall age presentation of these malignancies are basically delayed. They present late because maybe due to absence of serosa and the distensibility of esophagus, which delays the symptoms until the tumor is advanced. So we tend to find these tumors already in the advanced.
1 minute left. Please continue.
Yeah. So in our study, gastric biopsies constituted the major of the cases in coming to the lesions of the esophagus. And among the gastric biopsies, 86% were non-neoplastic, of which I told you chronic gastritis was the most common. In which subtype of the chronic gastritis, we saw H. pylori was the most common with 24.5%. And coming to our endoscopy and histopathological correlation, which was the main objective. So we saw the correlation between our endoscopy and histopathology with respect to the esophagus cases, and the lesions were around 93%. And in carcinoma stomach, the grade reduced to around 80%. And this may be due to, because again, as I told you, the esophageal carcinoma presents late in the disease course and hence can be picked up easily. But whereas in the stomach malignancy, the ulcers and the flat lesions, may lead to the disinterpretation of the dysplasia or another thing. So just briefly summarizing all the points. So the major sample we received were more of the biopsies, and the most common presenting complaint was the pain in abdomen, which the people presented with, and the malignant lesions were of course in the higher age groups, greater than 50 years. And we also saw that there were non-neoplastic lesions in most common in age of 61 to 70 years, which is the take-home message that you can get many non-neoplastic lesions in that age. So if we are getting a biopsy of the older age, do not think it to be a carcinoma. The most common lesion of esophagus was squamous cell carcinoma, and of the stomach in the non-neoplastic was the chronic gastritis. And the conclusion, yes, endoscopic biopsies can detect changing patterns in detecting upper GI mucosal lesions. Especially, we should be able to detect atrophy, the metaplasias, and the dysplasias, so we can warn the surgeons at the earliest. And in the absence of endoscopic screening, detections of these lesions may be missed. So the endoscopy and the histopathological correlation is very important. And upper GI endoscopy is relatively less invasive, simple and safe, and well tolerated also. And of course, it's the
time up, Dr. Akshay.
Yeah, sure. So it's done, ma'am. This is just the last sentence. Early detection of mucosal lesions and diagnosis leading to clinic. So these are my references. Thank you.
Over to judges.
Very good presentation, Dr. Akshay, and the images were very nice. Only 2 questions for you. Did you get any problem of adequacy of tissue? And number 2, what are the malignancies associated with H. pylori?
Yes, ma'am. The adequacy of the tissue was actually often problem what we used to diagnose. So as the junior residents, when we see the slides, we always feel that we cannot appreciate the mucosa and the submucous, like we're not able to see all the layers of the stomach properly. But once we informed the surgeons about it, the endoscopic biopsies were taken pretty good. So most of the samples which we received, at least 90% of them had a very good adequacy.
Okay, and malignancies associated with H. pylori?
Malignancies, ma'am, again, adenocarcinoma is very common malignancy, and maltoma of the stomach.
Yes, good.
Yes.
Thank you.
Yes, that was the question even I wanted to ask Dr. Akshay, that how do you handle inadequate samples?
Ma'am, to be very frank, we actually don't comment. We tell them to take a repeat biopsy if it's possible, ma'am. We leave it telling inadequate for biopsy, like inadequate for further interpretation. And
or have you ever missed a lesion on biopsy?
ma'am, we have missed, but we try to, anything which is coming apart from the endoscopy, what they're thinking, and if we are getting something else, we try to, get a good correlation with the surgeon. And if he also thinks that there is a doubt, then we go for a endoscopic biopsy again. But until then, yes, ma'am, we have, we usually sometimes the dysplasia and the carcinomas usually go for secondary reportings, in which we have doubt, and our senior lecturers, we generally get a doubt whether it's to call it a short dysplasia or can we call it a carcinoma.
Okay, good presentation.
Thank you.
Thank you to all the presenters. Thank you, Dr. Radhika ma'am. Your visibility kept us calm throughout. Thank you, Dr. Sabia ma'am, and thank you, everyone.
Thank you.
Thank you. Thank you, dear all. It was a nice. I was happy to be associated with all of you. Thanks a lot.
Thank you, Pagya madam. Thank you, Sabiha ma'am. And thank you, Huma ma'am. Thank you
for getting me on this platform. It was really good being here. Thank you.
I think we are moving with the next session of histo presentation. Dr. Swati ma'am.
Yeah, I'm there. Am I audible, Ankita?
Yes.
Okay. So I welcome you all on behalf of Team VAPM for today's histopathology paper presentation, session 2. And I would like to introduce you to our judges for today's session. Our first judge is our beloved teacher, Dr. and Head of Department at People's College of Medical Sciences, Bhopal. He has worked in GMC in various capacities, and he has retired from GMC Akola as Professor and Head of Department Pathology. Our second judge is Dr. Anjali Bode, madam. She is presently working as Assistant Professor, Department of Pathology, IGGMC Nagpur. I request all the presenters to be attentive. Each one of you will have 7 minutes for the presentations and 3 minutes for a question answer session. I request all of you to please abide by the timings. So shall we go ahead with the presentation, sir?
Yes, you go ahead.
Our first presenter for today is Dr. Divya Singh. Divya, are you there?
Yes, ma'am. Ma'am, am I audible?
Yeah, you're audible.
Okay, ma'am. Ma'am, is my screen visible?
Yeah. Yes, it is visible. Please put it on slideshow mode.
Okay, ma'am.
Everybody can see it clearly then.
Ma'am, is it visible now?
Yes, the screen is visible. Put on slideshow mode.
Ma'am, I have put it. Is it not visible?
Okay, go ahead.
Should I start, ma'am?
Yes, please do.
Good afternoon, teachers. Topic of my paper presentation is evaluation of Ki67 in prostatic carcinoma and its correlation with Gleason's score and other prognostic factors. I will be discussing my topic under the following headings: introduction, aims and objective, material and methods, result, discussion, and then conclusion. Introduction. Prostatic cancer is the second most commonly diagnosed malignancy and the sixth leading cause of cancer among men globally. And worldwide, prostatic carcinoma burden is expected to grow approximately 2.3 million new cases and 7,40,000.
Please move your slides.
Ji, sir?
Please move your slides. Only one first slide is visible. The slides are not visible.
Sir.
Go ahead. Now it's okay.
Is it okay, sir?
Now it's okay. Go ahead.
Okay.
Put it on a slideshow.
Ji, sir?
Full screen. Put it on a full screen slideshow. Or if not possible, go ahead.
Is it visible, sir?
Yeah, it's visible. Go ahead.
Prostatic cancer is the second most commonly diagnosed malignancy and the sixth leading cause of cancer death among men globally. Worldwide, prostatic carcinoma burden is expected to grow approximately 2.3 million new cases and 7,40,000 deaths by 2040, mainly due to growth and aging of the population. Risk factors: African Americans, age more than 65 years, family history, gene mutations such as BRCA1 and 2, high fat diet, high red meat diet, and smoking. Presenting symptoms: lower urinary tract symptoms such as urine frequency, terminal dribbling, nocturia, urgency, hesitancy, straining to void. Other symptoms such as visible hematuria, erectile dysfunction are also noted. Overall, most common histological type is adenocarcinoma, followed by others, that is SNR, intraductal and ductal adenocarcinoma. Gleason's grading system after Donald F. Gleason, and it was first described in 1960s and describes prostate tumor architecture and morphology. IHC has an important role in prostatic carcinoma diagnostic confirmation. Most frequent biomarkers studies are P53, Ki67, that is proliferation marker, ERG, MYC, proto-oncogene, P10, phosphatase tensin homolog, which are implicated in the control of cell proliferation and differentiation, angiogenesis, and apoptosis. Gleason's scoring: it depends on the architecture of the tumor. Grade is defined as sum of two most common patterns. Both primary predominant and secondary second most prevalent architecture patterns are identified. Here we can see 5 grade groups. In grade 1, there is 3+3 score, which is equivalent to 6. Mainly well-formed glands are seen. In 3+4 grade group 2, total score is 7. Mainly predominantly well-formed glands and some poorly formed glands. In 4+3, there is mainly poorly formed glands, and grade group is 3. In grade group 4, it includes 4+4, 5+3, and 3+5, while in grade group 5, there is 4+5, 5+4, and 5+3 Gleason score, and there are no glands and only sheets of cancer cells are present. Here in this picture, we can see H&E stain slides of 3+3 pattern, well-formed glands 3+4, and 4+3 pattern. And this is the high par view of 4+4, which shows cribriforming. And here in 5+5, there is solid sheets. Now, a brief introduction about Ki67. It reflects the tumor cell proliferation rate as it's correlate with the progression, metastasis, and prognosis in a number of different malignancies. Ki67 is involved during all active phases of the cell cycle, and absent in resting cells has made it an excellent marker for determining growth, tumor growth fraction. Here we can see that Ki67 is 30% in this grade group and 45%, and maximum it is seen in grade group 5, which is 95%. Aims and objective of my study is to assess different histological grades to assess Ki67 expression in prostatic carcinoma and to correlate Ki67 expression with Gleason's score and other prognostic factors. Material and methods. It is a prospective study which is carried out in our Department of Pathology of SRMS IMS Bareilly, and I have taken histopathologically confirmed specimen, and study duration is 1.5 years from November 19 to April 21. Sample size is 47 cases, and they were subjected to IC staining of Ki67. All nuclei with brown nuclear staining were rated as positive irrespective of intensity staining, and its activity was quantified using labeling index, in which a number of cells stained by Ki67 divided by total number of cells counted into 100. Now, statistically, an analysis was done using SPSS version 21 Minitab. Results of continuous variables are presented as mean plus minus standard deviation, and p-value less than 0.05 was considered as the cutoff value of the significance. Now the results here, it is shown that age-wise distribution of studies patient, in which maximum number of patients is in the category of 61 to 70 year. Locality-wise,
1 minute to go.
People, ji ma'am?
1 minute to go.
Okay, ma'am. Mainly rural population, and here all these serum PSA level, Gleason's grading and grade grouping, LVI and PNI correlation in my cases, Ki67 expression, and I have made correlation tables between Ki67 expression with USG findings, grade group, Gleason score, serum PSA level, prostatic volume, LVI and PNI, and significant correlation was found between Ki67 and grade group only, in which p-value is 0.042, which is less than 0.05. And in the present study, among 47 cases,
Divya, are you there? Divya, you are not audible.
ट्रेनिंग व्हायला पाहिजे प्रत्येकाचं ट्रेनिंगच नाही ना सर हा त्रास होतो
Divya
ते बटन दाबलं जातं
and these are the authors.
Dr. Divya, you are not audible and you are still not audible.
Yes, yes.
Ma'am, am I audible?
Yes, now you are.
Now you are.
Ma'am, my screen is visible?
No.
Yes.
No.
Is it?
Now it is visible.
Yes, now it is visible.
Divya, now you are visible. Please. Your voice is not audible. Swati?
Yes, ma'am.
What to do? She is not audible now.
I think we should go over to the next candidate, and if we can take. Hello.
She has almost completed. So better to go for the next paper.
Okay, sir.
Yes. Hello, Julie, are you there? Dr. Julie?
Yes, ma'am, I'm there.
Okay, please share your screen.
Okay.
Ma'am, am I audible now?
Sir, what should we do? Should we take her question answers?
Directly question answer we will take.
Divya?
Yes, ma'am.
Conclude.
Conclusion, 57.8% patient had grade 2 prostatomegaly on USG, and cases of adenocarcinoma only were taken in the study. Maximum number of cases, 22, was grouped under grade group 5, followed by 9 cases were grade group 4, and 26 cases had PNI, while only 14 cases had LVI. Majority 17 cases shows 51 to 75% Ki67, followed by 13 cases more than 2 to 25%. 9 fall in the category of 76 to 100%, and only 8 cases were in 26 to 50% Ki67 IHC expression. A statistically significant relationship between Gleason grade group and Ki67 labeling index, both of which maintain a linear and significantly increasing trend from lower grade to higher grade prostatic carcinomas. These are my references. Thank you.
Okay. In your head, you are told that the evaluation of Ki67 with Gleason's grading and other prognostic factors. Other prognostic factors you have studied?
Yes, sir.
Other prognostic factors? Which other prognostic factors you have studied? You have not mentioned in your presentation the other prognostic factors.
Sir, serum PSA levels, USG findings, lymphovascular invasion, perineural invasion.
And what was the correlation of Ki67 with them?
Sir, they were not statistically significant. Only one parameter was statistically significant, that is grade group.
Okay.
Others are insignificant.
Okay. So I think we can move to next if Anjali don't have any questions.
Only one question for Divya. Divya, what are the specific histopathological features for the malignancy in a diagnosis of prostatic adenocarcinoma? I want specific features.
Ma'am, firstly, there is loss of outer basal cell layer, which is intact in benign prostatic carcinoma, benign prostatic hyperplasia. And second, there is high MC ratio, prominent nuclei, irregular nuclear membrane, opened up chromatin. And
other than these, Divya, other than these, can you?
Ma'am, there is a loss of basal cell layer, and there is in BPH we saw corpora amylacia, while in malignancy there is crystalloids mainly.
Okay, okay, Divya. Thanks. Nice presentation.
Thank you, ma'am.
Next.
Thank you, sir.
Okay, Dr. Julie John, please share your screen. Dr. Julie?
Yes, ma'am. I'm sharing my screen.
All the presenters, please abide by your timings. We are already running short of time.
Ma'am, the previous participant needs to stop sharing the screen only, then I can share.
Dr. Divya? Dr. Divya, are you there?
Yes, ma'am.
Please, you stop sharing your screen so that the next participant can go ahead.
Okay, ma'am. Ma'am, I already stopped, I think.
Dr. Julie?
Yes, ma'am, I'm checking it.
Okay.
स्क्रीन शेअर काढलं त्याने स्टॉप केलं एकच झालं.
Is my screen visible?
Yes, now it is. Can you just put it on a slideshow mode?
Yes, ma'am. Shall I start?
Yes.
Go ahead.
Good evening, everyone. The title for my presentation is Study of Proliferative Indices using Mitotic Index and AGNOR and their correlation with various grades of breast carcinoma. Introduction. Breast cancer is one of the most common malignancies and leading cause of death in middle-aged women. It accounts for 13.7% of all cancer deaths in women. Altered proliferative activity as a prognostic factor is important as it points out to the biological aggressiveness and behavior of malignancy. This altered proliferative activity can be detected by mitotic figure counts, the count of nucleolar organizer regions, and also by Ki67. The ductal carcinoma of the breast can be graded using Nottingham modification of Bloom and Richardson scoring, which has 3 parameters: tubule formation, nuclear pleomorphism, and mitotic count. The nucleolar organizer regions are chromosomal loops of DNA involved in ribosomal synthesis. These nodes are located on each of short arms of chromosome 13, 14, 15, 21, and 22. These proteins are identified by silver colloid staining technique and visualized as dark intranuclear dots under the microscope. Silver staining is an easy and very quick technique that can be performed on formalin fixed paraffin embedded section. These dots are fine and dispersed singly in benign tumors. The dots are coarse and present in clusters in malignant tumors. Hence, AGNOR is a useful tool to differentiate various grades of malignancy. There are other techniques to estimate the proliferative indices that use immunohistochemistry. These techniques are expensive and need a lot of expertise. Therefore, this study is proposed to study the proliferative indices using AGNOR and to understand its correlation with various grades of breast carcinoma. Aim and objectives. My aim was to study the relationship of proliferative indices and various grades of breast carcinoma. Objectives: to study the mitotic index in breast carcinoma cases, to grade the lesions histologically, to study the AGNOR count in the same cases. Material and method. In this study, all the specimens of infiltrating ductal carcinoma of female breast belonging to all age groups received in the Department of Histopathology of Gajraraja Medical College, Gwalior during the period of 1.5 years were assessed and scored using Nottingham modification of Bloom and Richardson scoring. Sample size 50 cases. AGNOR count and mitotic index were calculated and correlated with histological grade. Correlation of these proliferative indices and various histological grades were determined. Inclusion criteria: only invasive ductal carcinoma of breast were included. Exclusion criteria: all benign lesions of breast like fibroadenosis and fibrocystic disease were excluded, and various other morphological benign proliferative lesions of breast were excluded. Staining procedure for AGNOR: sections were dewaxed in xylene hydrated through alcohols to water. Then the sections were rinsed and with deionized water 3 times. Sections were incubated with working staining solution for 45 minutes under dark room temperature conditions. Sections were washed with deionized water for 10 to 15 minutes. Sections were then dried in xylene and mounted in DPX mounting. The stained slides were viewed under oil immersion, and after counting intranuclear silver dots, at least 100 cells, AGNOR score was calculated, that is mean number of AGNOR dots per nucleus. My observations were: the distribution of participants in terms of age. The mean age was noted as 46.16. The range was 22 to 65 years. This graph shows the distribution of age with the mean age 46.16. Distribution of participants in terms of histological grade: 12% belonged to histological grade 1, 60% to grade 2, and 28% to grade 3. The percentage distribution according to histological grade, that is graphically represented over here. The association of histological and mitotic index were: the mitotic index in grade 1 was 4.42, the mean of mitotic index in histological grade 2 was 7.59, and mean of mitotic index in grade 3 was 12.2. Here we can see the mitotic index was great in grade 3. The comparison of 3 subgroups of variable histological grade in terms of AGNOR count was made, and the mean AGNOR count in histological grade 1 was 0. And the mean AGNOR count in grade 2 was 4.20. The mean AGNOR count in histological grade 3 was 6.14. The association between histological grade and AGNOR count is represented, and it was higher in grade 3. These were the pictures of grade 1 IDC, grade 2 IDC on HNE, and grade 3. These were the AGNOR pictures. Grade 2 infiltrating ductal carcinoma with an increased number of dark brown dots, and grade 3 with an increased number of dark brown dots with huge size spreading. Please continue. In our discussion, in our study, the age of patients ranged from 22 to 63 years. The mean age was 46.16. In the study of Athesham et al., of the patients ranged from 24 to 85 years with mean age 46.84. This was in concordance with our study. Histological grade: in our study, 12% of the participants had histological grade 1, 60%, grade 2, 28%, and grade, which was in concordance with study conducted by Blamey et al. In 2009, having grade 1, 29%, 2, 41%, and 3, 30%. AGNOR count: in the present study, mean AGNOR count was 4.24. In studies by Nepal and et al., Ansari and et al., and Simha et al., AGNOR counts were 4.5, 4, and 3. These studies were in concordance with our study. Mitotic index: in our study, the mean mitotic index of histological grade 1, 2, 3 was 4.42, 7.59, and 12.2. In the study conducted by Lik Han Lee at mitotic count per 10 HPF grade 1, 2, and 3 was 5.5, 9.52, and 53.24. This was in concordance with our study. Conclusion: high EGNOR counts in higher grades of breast carcinoma showed that with higher grade, the cancer peaks in its proliferation and aggressiveness and has higher number of cells which are mitotically active when compared with lower grade of malignant cases. EGNOR staining is a simple procedure for measuring the cellular proliferative activity and uses light microscopy for visualizing. IHC techniques are known to be expensive compared with EGNOR, which is a cheaper technique. The use of EGNOR and mitotic index has the advantage that it can be used with the material that we obtain for routine process in histological laboratory, and we do not need any special fixation. EGNOR staining and mitotic indexing are cheaper and can be useful tools to discriminate between low and high grade tumors and can guide in management of patients. EGNOR and mitotic index showed a good positive correlation with the Bloom and Richardson grading system, and the EGNOR values increased as the histological grade of the neoplasm progressed higher. These are my references.
Okay, Julie.
Yes.
For counting mitotic figures, have you used any specialized grid or it is done with the routine microscope?
Routine microscopy only, sir, was used.
So you have counted with the high power, 10 high power fields.
Yes, sir.
Actual counting with the grid is
the mean was taken of 10 high power fields using 1 to 6 sets.
okay. Okay, all right. Dr. Anjali?
Julie, in your data, not a single case of grade 1 was EGNOR positive, right?
Yes, ma'am.
Why so?
Ma'am, we didn't find it that way. The EGNOR counts were not there.
So
we only counted the coarse dots.
In grade 2 and grade 3 only. And what about
Yes,
in grade 1? Not a single dot you found?
Yes, ma'am, I didn't find in grade 1.
Okay. Okay, Julie.
Nice,
Thanks. Nice presentation.
Next presenter is Dr. Manjeet Durve. Dr. Manjeet. Dr. Manjeet.
इन्हें ऑफ करायला पाहिजे ना पहिले. Just screen चालू आहे.
Dr. Manjeet.
Yeah, good evening, ma'am. Good evening. I am here, ma'am.
Please share your screen.
Yes, ma'am.
Julie. Okay.
Jabalpur chair. E16 protein and survival.
Manjeet, put it on slideshow mode. Yes.
Ji, ma'am. Ji, ma'am. Ma'am, I am audible, ma'am.
Yes, yes. Go ahead.
Is it visible, ma'am?
Yes.
Yes, yes, it's visible.
Oh, okay.
Please start.
Ji, ma'am. Good evening, respected sir and ma'am. Today, myself, Dr. Manjeet, I am going to present a paper on expression of P16 protein in cervical intraepithelial neoplasia and invasive carcinoma of uterine cervix. Uterine cervix is vulnerable to wide range of inflammatory and neoplastic pathologies. Lesions of the cervix occur in all age groups, but they are more common in young sexually active women. Within estimated 604,000 new cases and the 342,000 deaths worldwide 2020. Cervical cancer not only ranks fourth most common only diagnosed cancer, but also the fourth leading cause of cancer death in developing countries. The vast majority of cervical cancer cases are caused by infection with certain subtype of HPV. HPV, a sexually transmitted virus, that infect the cells, result in the precancer invasive cancer. At a given time, in the general population, about 7.9% of women are estimated cervical HPV infection. HPV 16 and 18 are attributed to 82.5% of invasive cervical cancer. Cervical cancer is a rare long-term effect of the persistent infection of the lower uterine tract infection by the high risk of HPV type, which is termed as necessary cause of cervical cancer. The protein P16 is integral to retinoblastoma mediated counter of the G1-2S phase transition of the cell cycle by the inactivating the cyclin-dependent kinase that phosphorate the RB protein This is the reciprocal relation between P16 and the RB gene. There is upregulation of the tumor suppressor gene P16, which is a cyclin-dependent kinase inhibitor. The E7 protein of the HPV bind and inactivate the RB, which leads to the release of E2F, which is a transcription factor. Then it turns and activate the genes required for the entry into the S phase of the cell cycle, then result in increased level of P16 through a negative feedback mechanism. So there is interference of the viral oncoprotein with the cellular protein involved in the cell cycle. Regulation indicate overexpression of P16. The protein P16 is overexpressed in the cervical intraepithelial neoplasia and the invasive cancer. P16 serve as a surrogate marker for P16 for oncogene activity of HPV in replication component cells in cervical epithelia. The study has conducted its prospective study to evaluate the P16 as a biomarker in dysplastic and the malignant alteration of the cervical epithelium. Our study is a process study, 2-year duration from January 2020 to September 2021, conducted in our medical college, Jabalpur. Ethical clearance of the study was taken from the ethic board. Total 58 cervical biopsy were collected, out of which 21 cases were carcinoma cervix and 31 cases were SIN. Several randomly selected cases of normal cervical from the hysterectomy were studied to know the negative association between P16. Cervical dysplasia was classified using SIN classification, and the cervical carcinoma was classified according to WHO histological of invasive carcinoma of uterine cervix. Now come to the result. The P16 expression was absent in normal cervical epithelium in all cases, but it is increased from 25% positive cases in SIN1 to 86.36% cases of SIN3 showing positivity, and 92.85% of the squamous cell carcinoma and the 71.42% cases of adenocarcinoma shows overexpression of P16. Then this slide showing the first slide showing the chronic cervicitis HN staining, and the in second slide in chronic cervicitis showing the ISC negative for the P16, and the second in SIN1 there is showing the positivity for P16, and under these both slides for the SIN3 and the squamous cell carcinoma both are showing the P16 positivity. Then come to the discussion. There is slight discordance was seen in the P16 expression of SIN2 and the SIN3 in our study as compared to 75 to 100% expression reported in the most of the earlier study. The explanation for the same could be attributed to technical reasons, improper fixation, or different clonal antibodies if used. Then comparison of P16 expression in the cervical neoplasia with the various study. So out of 21 cases of carcinoma cervix, where 31 were the squamous cell carcinoma, 7 were adenocarcinoma. In our maximum cases, 92.85 was squamous cell carcinoma, and the 71.42 show positivity expression for P16, which is similar to the study by Murphy et al., Kishore et al., Srivastava et al., Lenuska et al., Kumari and Volganer et al. Then, however, we had one case of squamous cell carcinoma which are negative for P16 protein. The absence of P16 expression in the squamous cell of cervix may be due to absence of HPV infection, improper ISC technique, mutation in the epigenetic mechanism, and the hypermethylation. So there is a study to Gupta's. This study is concerned with the Gupta's and Volganer show the P16 negativity that exists. In our study, we impression made P16 over histopathological generated data analyzed for the between two methods. We found significant difference between P16 is for squamous cell carcinoma, 100% for sensitivity, specific 98%, positive predictive 93, negative 100%, and the positive predictive less than 0.05. Now I come to the conclusion. P16 were observed in the pre-neoplastic lesion of cervical cervix in 1, 2, and 3. Significant upregulation of P16 observed in cervical carcinoma and increasing PC expression increasing progressively. No positive staining of P16 observed in benign cervical epithelium. Using P16 as an adjuvant to the histopathology will definitely help explain the reporting of intraepithelial lesion. The present study demonstrated that significance of P16 overexpression of the squamous cell carcinoma. Further, HPV DNA detection based study are needed. Limitation of studies related to a small sample size. And then A coordinated integrative effort from the gynecologist, pathologist, and the oncologist can build a capable workforce reaching our goal and eradication of cervical cancer by the vaccination, screening, and treatment. Thank you. This is my reference. Thank you, sir.
Okay. Thank you, Manjit. Nice presentation. I'd like to ask you, what you use as a negative control? You use a negative control in this study?
Yes, sir. Yes, sir. Benign. Sir, chronic cervicitis we taken as a negative control.
So how many negative controls you have taken?
Negatives. The total we have 50 cervical biopsy.
I'm asking you controls, where the P16 will be totally negative. What you are saying?
Yes, sir. About 40 cases.
Okay, total cases are 40.
Yes, sir.
And as it is upgrading, like the CN2, CN3 will be positivity more as compared to CN1. What?
Yes, sir. Yes, sir.
Case of invasive malignancy, it was highest rather.
Yes, yes, sir.
Have you studied some adenocarcinomas in this?
Excuse me, sir. What is that?
Have you studied adenocarcinoma also?
Yes, sir. Yes, sir. Yes, 7 cases we had, sir. Adenocarcinoma. 7 cases.
They were also positive.
Yes, sir. Yes, positive.
Okay.
Dr. Manjit, one question for you. Expression of P16 has some prognostic significance or what?
Yes, ma'am. If P16 is positive, then patient may go and land up into the carcinoma. Is it a prognosis?
So it is prognostically bad or good?
Ma'am, good for the survival of the patient.
Or both for the survival. Okay. One question. What are the factors responsible for the progression of LSIL to HSIL or invasive carcinoma?
Ma'am, first of all, the age factor is most important. As the age increases, the patient is. Ma'am, as the age is increases, there is a chances of patient going to CN1, CN2, then the carcinoma.
Other than age?
Ma'am,
okay, Manjit, that's okay. Nice presentation. Yeah.
Thank you.
Our next presenter, Dr. Pradeep Kumar Reddy. Dr. Pradeep, are you there?
Yes, ma'am.
Please share your screen.
Sure, ma'am.
तुम लीव कर दो मेरा ये.
हे चांगले होते. पहिले तिन्ही चांगले होते. काय म्हणतोय? Correlation of endometrial hyperplasia.
Pradeep, shall we start?
Yes, ma'am. Ma'am, is my presentation visible, ma'am?
Yes.
It is visible. You go ahead.
Thank you. Thank you, sir. Good afternoon, everyone. Myself, Dr. Pradeep Kumar Reddy, M. Today, presenting this paper titled Clinico-Pathological Correlation of Endometrial Hyperplasias with Progesterone Receptor Expression in DUB. Introduction. Dysfunctional uterine bleeding is a diagnosis of exclusion used by the gynecologists where there is no specific cause found. There are other lesions, anatomical lesions, systemic diseases associated with abnormal uterine bleeding, which are not categorized as DUB. Menorrhagia is a most common complaint to the gynecologist, and 50% of these menorrhagia cases are clinically diagnosed as DUB. Various histopathological patterns found in DUB include these precancerous lesions of endometrial hyperplasias, as we have seen in the references. Then endometrial hyperplasias are very much treatable. They are to follow certain monitoring guidelines, and successfully cancer can be prevented. Women with these lesions who want to conceive and those who don't opt for hysterectomy are ideal for such conservative therapy with hormones. Earlier classification of endometrial hyperplasia included 4 groups, which was non-atypical endometrial hyperplasia and atypical with simple and complex in each group. Then the latest WHO classification includes only 2 headings, endometrial hyperplasia without atypia and endometrial atypical hyperplasia. Progestins are popular therapeutic agents which certain other synthetic drugs like a selective progesterone receptor modulators, which modulate the PR receptor and act on the endometrium. Now, these are used in the treatment with certain diseases like hyperplasias. Then PR as a marker has been widely studied by many for its prognostic and diagnostic roles. And we can see those references. Objectives of the study, first to study PR immunoreactivity of endometrial hyperplasias diagnosed in DUB patients. Then also to explore the PR expression with other parameters like patient age and parity. Then materials and methods. This was an observational study done retrospectively between June 2019 and November 2020 for 1.5 years. Endometrial samples of DUB patients diagnosed as endometrial hyperplasia in the Department of Pathology at our tertiary care center were taken for the study. Clinical history was included with age, parity, and presenting complaints. Paraffin embedded endometrial sample blocks were taken for IHC to detect PR expression in them. PR expression was assessed by Aldred score, which is a semi-quantitative method. Inclusion criteria were endometrial samples, curettage and biopsy samples from patients diagnosed as DUB by clinicians. Samples also diagnosed as endometrial hyperplasia in the Department of Pathology. Exclusion criteria were those that were diagnosed as DUB by clinicians but were found to have pregnancy-related complications, genital tract lesions, systemic causes, coagulation defects, etc. Then hysterectomy samples also were excluded. Sample size was 40. Statistics used were frequencies and percentages for categorical data, while chi-square test was used for associations between variables with p-value of less than 0.05 considered significant. Aldred scoring system was used for PR expression assessment. Aldred score basically has proportional score, intensity score, adding up which you get the Aldred score. Proportion score is the percentage of the tumor cells, as we can see, that have been stained by the marker. 1 less than 1%, 2 is 1 to 10%, 3 is 10 to 33%, 4 is 33 to 66, and 5 is more than 66% of cells stained with the marker. Intensity is 0 is negative, 1 is weak intensity, 2 is moderate intensity, 3 is strong intensity of staining. Adding up which we could get scores from 0 to 8, 0 to 2 are negative, 3 very poor, 4, 5 poor, 6 intermediate, 7 and 8 rich scores. Now, coming to the results, age distribution, we can see that most of the endometrial hyperplasias were seen in the age group of 40 to 49, which is the perimenopausal age group, followed by the reproductive age group of 30 to 39 years. Parity distribution, majority of the cases were in multiparous women, 37.5% each in parity 2 and parity 3. Presenting complaint, menorrhagia was the chief presenting complaint, dysmenorrhea, polymenorrhea, menorrhagia, and postmenopausal bleeding being few others. 65% was seen with menorrhagia. Microscopic impression, according to the old classification, simple endometrial hyperplasia without ATPR dominated with 90%, remaining were only few, which included complex with and without ATPR, and simple endometrial hyperplasia with focal ATPR, which was only one case. And then we can see here that the gland architecture in the pie diagram, only 3 cases were complex, rest all were simple architecture. Histopathological diagnosis with the new WHO classification, including endometrial hyperplasia without ATPR, were seen in 92.5% of the cases, which predominated. Very few or only 3 cases, 7.5% of them were atypical, endometrial atypical hyperplasia. PR expression and Aldred score in general, with all the hyperplasias, majority of the endometrial hyperplasias were showed rich score of 7 and 8, whereas 27.5% of them also showed variations with intermediate, poor, and very poor staining. None of them were negative. Age expression with PR, we can see that the PR scores with age are scattered everywhere. There's no fixed criteria, and the P value, the chi-square test for both the variables of age and PR is also not significant, 0.423. Then parity with PR expression, we can see a very good association here. Score parity 0 shows very poor immunoreactivity, one case, and parity 1 had poor, very poor and intermediate reactivity. Parity 2 showed intermediate and rich reactivity. Parity 3 and 4 showed only rich. So as the parity increased, the PR expression also increased. So nulliparous and primipara were having less PR expression. And chi-square also was very, test was very significant with a p-value of less than 0.111. Presenting complaint with PR expression. Presenting complaint, this was also significant according to the chi-square. So we can see that in menorrhagia, which was the chief complaint, where with most of the cases, PR expression scores were scattered. And with the dysmenorrhea, metrorrhagia, polymenorrhea, they were mostly rich immunoreactivity, whereas postmenopausal bleeding was poor immunoreactivity, because of which they can be seen that significant P score is there. However, the other cases, the other numbers were very low. Then microscopic impression with PR. Here also we can see that majority of the cases were simple endometrial hyperplasia without ADPia as per the old classification. The others were very few, and there were variations in the score, as we can see here, with a very poor score in 1, poor immunoreactivity in 2, intermediate scores of 6 with 7 cases, and rich scores with 26. Histopathological diagnosis of the latest WHO classification, endometrial hyperplasia without ATPia, there were 37 cases, 3 only were with ATPia. So again, the same kind of pattern can be seen here, wherein there is a majority of the cases with rich PR expression, while 10 cases had other intermediate and poorer expressions. Now, these are certain pictures showing the IHC marker staining. The first image, endometrial hyperplasia without ATPia. On the left side, you can see the ALDRET score of 8 is seen. It's a simple endometrial hyperplasia. PR proportion score is 5, wherein all the epithelial cells are stained, and the intensity is also quite good compared to the control on the right side. Then this is the second one with ALDRET score 6, wherein proportion score is 3. Meaning up to 33%, between 10 and 33% of the cells are stained. Then intensity score is 3, which is similar to the control. Then this is the third one with the ALDRET score 5, simple endometrial hyperplasia with a PR proportional score of 3, up to 33%, between 10 and 33%. Intensity was intermediate, so it is given a score of 2, ALDRET score of 5. This is the control on the right side. Then this is the fourth one, where you can see that there is a complex architecture without ATPia. So this is also an endometrial hyperplasia without ATPia with PR, ALDRET score 8. It is showing very rich immunoreactivity, and the control on the right side. Then this one is another complex architecture, endometrial atypical hyperplasia, where you can see that there is ATPia in the epithelial cells, and it is strongly stained with a stain of ALDRET score of 8, 5 proportional plus 3 intensity. Discussion with the literature. We know that PR can be a prognostic marker and diagnostic in limited settings. Passam et al., Bergeron et al., and Niholm et al. Have discussed PR expression to be high in endometrial hyperplasias without ATPia, low in EAH, and still lower in endometrial carcinoma. Zidane et al. In their study on endometrial hyperplasias and carcinomas found that decreasing levels of PR related to increase in invasive cancer risk, and it plays a significant role in the development of endometrial cancer. Loss of PRs is known to indicate a poorer prognosis in endometrial cancer. With this kind of literature, now in the current study, we'll see that endometrial hyperplasias as a whole were all positive for PR expression, with majority of 72.5% showing ALDRET rich scores. However, there was variations with intermediate, poor, and very poor scores in 27.5% of the cases. In the subtypes also, a similar fashion was seen, wherein 73%. Yes, 73% of the cases were rich, and the others were showing varied things. Then there was no significant difference between the PR of the two types. Then, however, definitive interpretation is difficult because of the very few EH cases. Then complex endometrial hyperplasia with and without ATPs showed rich ALDRET scores. Age with PR expression had no association. Parity showed a strong association, and also seen in Bu et al. In his studies with endometrial risk and parity. Then presenting complaint, PR expression, there was certain kind of significant p-value, but because the numbers were less, we could not give a definitive result. Discussion came with these derivations. The cases with loss of PR expression in hyperplasias could be targeted for higher carcinoma risk, helping in improving preventive measures and reducing the load of endometrial carcinoma in the society. These cases could be shortlisted for molecular testing as well to save resources. Further in-depth studies should be carried out on factors affecting PR loss in hyperplasias to better understand carcinogenesis and prevent endometrial cancer. Now, conclusion, PR expression in different categories of endometrial hyperplasias is variable. Now, this variability in the same category points towards factors that may affect it. PR expression increases with parity. In-depth, these studies have to be conducted on those factors to understand carcinogenesis and prevention of endometrial cancer is recommended. PR can be used as a valuable and cost-effective prognostic tool to prevent and reduce the load of endometrial cancer in the society. These are my references.
Okay, Dr. Pradeep, had a very good presentation. Let me ask you, have you ever had any cases of EIN, that is endometrial intraepithelial neoplasm study?
Yes, sir. We had 2 cases.
Of EIN.
Sorry, sir?
EIN, I am asking you, endometrial intraepithelial neoplasia.
It is endometrioid intraepithelial neoplasia according to the latest classification, sir.
Yes.
Endometrial atypical hyperplasia is also known as endometrioid intraepithelial carcinoma.
Neoplasia, yes.
Yes, neoplasia.
It is one step ahead of atypical hyperplasia in the newer classification, literature 2016. And did the PR in those cases?
Yes, sir. We did PR and we got rich staining, sir. PR score was 8 in both of them, sir. We had 2 cases and both of them had a rich score, sir. Rich Aldred score.
Okay. Okay, all right.
Thank you, sir.
Dr. Pradeep?
Yes, ma'am.
Will you tell me what is essential and desirable diagnostic criteria for endometrial atypical hyperplasia or EIN?
Ma'am, essential criteria are those that the epithelium in the epithelial cells should have lost their polarity, ma'am, and there could be nuclear changes like hyperchromatism and increased nucleochromatic ratio, ma'am.
And what about the desirable criteria?
Ma'am, desirable criteria for this could be mitotic figures, maybe, ma'am.
Okay, Dr. Pradeep, thanks.
Thank you.
Your images was nice. Thanks for the presentation.
Thank you very much.
Thank you, Dr. Pradeep. Our next presenter is Dr. Riya Yadav. Dr. Riya? Dr. Riya Yadav. I think she has not logged in.
P16.
Next then.
Next, Dr. Simranjeet Kaur. Are you there? Dr. Simranjeet Kaur?
She is also, I think, not here.
Okay. So the next presenter, Dr. Suparna Chatterjee. Dr. Suparna?
Yes, ma'am. I think she's here.
Yeah. Suparna, can you please share your screen?
Yes, ma'am.
GIT. नागपूरची जाईल नागरिक.
Please go ahead with your presentation.
Okay, ma'am. Good evening, everyone. My topic is histopathological spectrum of lesions of lower gastrointestinal tract in children at the tertiary care hospital. My aims and objectives are to ascertain the prevalence of various lower gastrointestinal tract diseases according to the pathological diagnosis in the Indian pediatric population, and to analyze the pathological findings of various lower gastrointestinal tract diseases in the children. So conventionally, the lower gastrointestinal tract starts at the cecum as a blind pouch and continues as ascending, transverse, descending sigmoid colon and ending into the rectum and the anal canal. In the pediatric population, the spectrum of the surgical pathology is much wider, and the pathology related to the congenital anomalies and immature development are most commonly seen in contrast to the adult population.
Symptoms related to the lower gastrointestinal tract symptoms are the major causes of hospital visit for the children. This could be in the form of diarrhea, constipation, abdominal pain, or rectal bleeding. So the diseases affecting the lower gastrointestinal tract in children could be divided into congenital abnormalities and acquired lesions. Like in congenital abnormalities, the anorectal malformation, intestinal atresia and stenosis, duplication of the gastrointestinal tract, meconium abnormalities, Hirschsprung disease, and malrotation. In acquired lesion, gastrointestinal tract infection, inflammatory bowel disease, necrotizing enterocolitis, spontaneous perforation of the gastrointestinal tract, polyps, intussusception, and neoplasm. My materials and methods are, it is a prospective study done over a 1-year period from January 2020 to January 2021 in TNMC Bivaler 9 Hospital. The total sample size are 40 cases. Under study population, all the pediatric patients up to the age of 18 years who have undergone lower gastrointestinal tract, endoscopic biopsy, or surgical procedure, or any specimen received in the surgical histopathology. All the specimens were received in 10% formalin solution, routinely processed, gross pathological parameters are noted, sections were taken and stained with normal H&E staining, and the microscopic examination are done. And whenever possible, the special stainings are done like AFB staining. So in our observation, the disease spectrum are like that: 10 cases of the anorectal malformation, 8 cases of Hirschsprung disease under colitis, 5 cases of tubercular colitis, 3 cases of inflammatory bowel disease, 1 case of eosinophilic colitis, and 1 case of amoebic colitis, and 5 cases of non-specific colitis. Under polyps, 4 cases of juvenile polyp, 1 case of inflammatory polyp, and 1 case of familial adenomatous polyp, and 1 case of solitary rectal ulcer. Anorectal malformation consists of spectrum of malformation, ranges from a thin membrane which obstructs the normal rectum and the anus to atresia of the entire distal rectum, in which the proximal rectum ends as a blind pouch. Sometimes this blind pouch can form fistula with the anterior structure, like in male, it can form fistula with the prostate, forming rectoprostatic lesion. In female, like it can form fistula with the vagina of the vestibule, forming vestibular fistula. So according to the level in which this distal end of the rectum comes with the levator hernia, it forms high, intermediate, and low. So in our study, male forming most commonly the high type of the anorectal malformation, but females are forming the intermediate. Children presented at different stages of treatment, like one of the most male patient who presented at birth with low anorectal malformation like perianal fistula, he underwent anoplasty at day 10 of the birth. And all the male patients who had high anorectal malformation undergo 3-stage procedure. That is, sigmoid colostomy was done at birth to allow the fetus to pass, and then around 9 months to 1 year of the age, definitive surgery in the form of anorectoplasty was done. Followed by 4 to 5 months later, colostomy closure is done. And all male patient with intermediate ARM undergo single-stage procedure around 3 to 6 months of age. In all female patient with low or intermediate anorectal malformation, they undergo 1-stage surgery around 3 to 6 months of age in the form of anorectoplasty. But sometimes this female patient, according to their condition, it can undergo 3-stage procedure also. This is a case of female patient with a vestibular fistula, and there is no anal opening. This is a case of cloaca with no anal opening. Hirschsprung disease is characterized by absence of ganglion cells in the distal gastrointestinal tract, which leads to the persistent contraction of the affected segment and subsequent obstruction. It results from defective migration of the neural crest cells craniocaudally. So according to the migration, if the ganglionic segment is limited to the rectum and the distal sigmoid colon, it is known as short segment. If it reaches up to the splenic flexure and transverse colon, then it is known as long segment. When it reaches up to the terminal ileum, then it is known as total colonic aganglionosis. So the commonest type in our study is short segment, and males are most
Dr.
commonly
Suparna,
affected.
1 minute to go.
Yes,
Please
ma'am.
continue. 1 minute to go. Please continue.
Most common symptoms being abdominal distension with failure to pass meconium. When the newborn baby presented with delayed passage of meconium, treatment in the form of rectal vas was given. To prevent the complication, full thickness biopsy was done, and during colostomy was followed 12 when the baby gains a 12 kg or till 1.5 years. For confirmation, full thickness rectal biopsy and barium enema was done, which is followed by a single stage through procedure. So in our study, 2 of the newborn cases were presented with a neonatal intestinal obstruction who underwent colostomy at birth, and full thickness biopsy was done at different levels to ascertain the level of the aganglionic segment. And 6 cases presented between the age of 1 month to 1 year, in which full thickness rectal biopsy was done, which showed no ganglion cells, which is supported by the barium enema study. Here we can see the ganglion cells present in the mesenteric plexus, which was taken during the frozen section from the proximal resection margin. Here we can see the secondary hypertrophic submucosal nerve bundles where no ganglion cells are found. We received 5 cases of tuberculous colitis, all cases presented between 10 to 18 years of age. Most common symptoms were the abdominal pain with the fever. Only 2 cases had a confirmed contact history, and CT finding shows all cases with thickened distal ileum, ileocecal junction, and cecum. Most common colonoscopic finding was transverse colon, and the most common histologic finding was confluent granulomas with caseous necrosis. Here we can see the confluent granulomas. This is the high power, which was surrounded by a cup of lymphocytes. Total 3 cases of inflammatory bowel, in which 2 cases of Crohn's disease and 1 case of ulcerative colitis. All the patients presented during 10 to 18 years of age, and most common clinical manifestation of ulcerative colitis are diarrhea, but in Crohn's it was abdominal pain. The spectrum of the histologic findings in ulcerative colitis are ulcer with cryptitis and crypt abscess and crypt distortion, but in Crohn's there was another finding of non-patientic granuloma. Here we can see the diffuse lymphoplasmacytic infiltrate with destruction of the crypts with crypt branching. Here we can see the crypt abscess formation. Here we can see the Crohn's disease with marked lymphoplasmacytic infiltrate going into the submucosa. And here we can see the non-patientic granuloma of Crohn's disease. There was a single case of female child with 18 years who presented with rectal bleeding with straining during the defecation. On colonoscopic, there was an ulcer at the distal end of the rectum. On microscopic finding, there was a crypts are normal, but there is a hypertrophy of the muscularis mucosae and splaying of the muscle fiber in between the crypts, giving it a diagnosis of solitary rectal ulcer. There was a single case of MAB colitis of 17-year-old male child who presented with the increased stool frequency associated with abdominal pain and distension. On stool examination,
Dr.
Yes,
Suparna,
sure.
take it fast.
Here we can see the trophozoite of the anterior histolytica, which is surrounded by neutrophilic exudate in the colon. There was a single case of 17-year-old male child who presented with abdominal distension and increased stool frequency. Actually, the patient presented with a strongyloid infection in the duodenum, but eosinophilic infiltrates are found in the colonic biopsies. There were 4 cases of juvenile polyps, which all came 1 year to 5 years of the age, and all presented with a bleeding per rectum. Here we can see the colonic polyp with ulcerated surface epithelium and benign glands in the subepithelial.
How much time left?
Ma'am, only 3-4 slides are left.
Please, can you just make it fast? We are running late
Sure, ma'am. Sure.
The session. Yeah.
Another single case of inflammatory polyp is there. And another single case of familial adenomatous polyp, who is a 11-year-old male child presented with a bleeding per rectum. There were multiple polyps in the stomach, also in the rectum. Here we can see the polypoidal growth in the colon, and there is the adenomatous changes. This is the gastric polypoidal growth showing adenomatous changes. So the conclusion is lower gastrointestinal pathology in the pediatric population has different spectrum than the adult and require different approach. Clinically, radiologically, and colonoscopic findings may be overlapping, but a definitive diagnosis can only be given on histopathological diseases. And inflammatory diseases, congenital anomalies, and Hirschsprung disease are the commonest disorder and need specific pathological diagnosis for proper management. Yes, ma'am, I'm done.
Okay. You haven't got any malignant cases?
Malignancy.
No malignancies?
No, sir, actually, we haven't received any biopsy or surgical specimen of malignancy.
These specimens were biopsies or they were the total colonostomy or colonectomy?
Sir, all are included, biopsy also, surgical specimens also.
All right, okay. Nice.
Yeah. Same question, Suparna, you haven't any malignancy in your study actually. Otherwise, it's nice. One question, will you please tell me the other manifest along with the inflammatory bowel disease, many cases of inflammatory bowel disease was there, right?
Yes, ma'am.
So extraintestinal manifestation, hepatic and dermato or muscular, any in your cases,
yes.
In your study?
Not in my study, but we can get erythema nodosum.
But not in your study, no?
No, not in my study.
Okay. Yeah, thanks.
Thank you.
Okay, our next presenter is Dr. Swati Nagre. Dr. Swati, are you there?
Yes, ma'am. Yes, ma'am.
Please share your screen.
Yes, ma'am. I'm sharing. Ma'am, it is visible?
Yes, it is visible.
Go ahead.
Yes.
Just put it on slideshow mode.
Yes. Should I start?
Okay, you can start.
Good evening, teachers. Myself, Dr. Swati Nagre, presenting the paper on histomorphological patterns of thyroid neoplasm in thyroidectomy specimen, 2 years cross-sectional study. Thyroid neoplasm represent the most common malignancy of endocrine system. Their incidence is rapidly increasing, and it is partially attributed to increased awareness and earlier detection of asymptomatic tumor. They present clinically as a nodular or diffuse mass lesion of the thyroids, similar to the non-neoplastic lesions. A wide spectrum of thyroid neoplasms is encountered, and histopathology evaluation is crucial to establish diagnosis. In the recent years, WHO 4th edition 2017 proposed classification of encapsulated, well-differentiated follicular pattern tumors. Survival of patients with thyroid neoplasm depends upon several prognostic factors such as age, sex, tumor size, tumor encapsulation, lymph node metastasis, distant metastasis, and other factors. Objectives of my study are: primary objective is to study the histomorphological spectrum of thyroid neoplasm, and secondary objective is to study the prognostic factors of thyroid neoplasm based upon histomorphology. Our study is a prospective cross-sectional study. We had done over the period of 2 hours, and in the Department of Pathology, Government Medical College Hospital, Nagpur. Thyroidectomy specimen including lobectomy, partial thyroidectomy, subtotal thyroidectomy, and total thyroidectomy included in our study, and non-neoplastic thyroid lesions were excluded. Detailed information of the patient regarding age, gender, clinical details, FNAC finding, USG reports, and operative finding obtained from the histopathological requisition forms and were recorded. Gross features of the specimen received were recorded. Representative sections were taken, and after the tissue processing, routine staining was carried out with hematoxylin and eosin stain. The thyroid lesions were classified as per the recent WHO histopathological classification of thyroid tumors. We were received total 225 thyroidectomy specimens. Among them, 135 were non-neoplastic and 90 were neoplastic lesion, which were included in the present study. The table showing age and gender-wise distribution showed the showing the female preponderance, that is total 77 female cases and 13 male cases, with female to male ratio is 5.92 is to 1. The frequency of various thyroid neoplasm The follicular adenoma is the commonest benign neoplasm, and papillary thyroid carcinoma is the commonest malignant thyroid neoplasm, followed by medullary thyroid carcinoma, follicular thyroid carcinoma, and we had also identified the one case of secondaries of IDC breast in thyroid. The age-wise distribution of thyroid neoplasm is the follicular adenoma is commonly seen in the 3rd to 5th decade of life, and papillary thyroid carcinoma is commonly in the 3rd to 6th decade of life, and follicular and medullary carcinoma in 3rd to 4th decade. These are the various prognostic factors we had studied. These are age, gender, tumor stage, lymph node metastasis, distant metastasis, multicentricity, capsular invasion, vascular invasion, extrathyroidal extension, lymphocytic infiltration, and the necrosis. The gross and microscopic image shows the encapsulated solid gray white tumor on microscopy showing variable size follicle lines by cuboidal epithelium compressing the surrounding thyroid tissue of follicular adenoma. The gross image showing well circumscribed tan to brown tumor. On microscopy, these are variable size follicle lined by neoplastic cell with abundant granular eosinophilic cytoplasm. The feature suggestive of Hurdle cell adenoma. Microscopic image is showing the mushroom-like invasion of the capsule by the follicles lined by the cuboidal epithelial cell without nuclear feature of papillary thyroid carcinoma. The features are suggestive of follicular carcinoma. The gross image showing encapsulated solid gray white tumor with papillary excrescences. On microscopy shows the papillae with fibrovascular core lined by neoplastic cell with nuclear overlapping, orphan and eye-like nuclei, nuclear grooving. These are the nuclear characteristic of PTC. Feature suggestive of papillary thyroid carcinoma. The gross image showing well circumscribed tumor, solid gray white, and on microscopy the multiple variable size follicles which are lined by neoplastic cell with nuclear feature of papillary thyroid carcinoma. The feature suggestive of follicular variant of papillary thyroid carcinoma. The microscopic image showing encapsulated tumor showing follicles lined by neoplastic cell with nuclear feature of papillary thyroid carcinoma. It is a encapsulated variant of papillary thyroid carcinoma. The microscopic image showing lymph node metastasis of papillary thyroid carcinoma. The microscopic image showing tumor with insular and lobular growth pattern with round to oval cell having coarsely clumped chromatin and amphiphilic cytoplasm, features suggestive of medullary thyroid carcinoma. The image showing the stromal amyloid deposit in on EHE stain and on Congo red stain. Lymph node metastasis of medullary thyroid carcinoma. Coming to the discussion, thyroid tumors account for approximately 1% of all malignancy of endocrine system. There were total 77 female cases and 13 male cases in our study, with female to male ratio is 5.9:1. Similar studied where some similar results were obtained by the Ramesh V et al. And Jagdale K et al. Female preponderance is considered to be due to the physiological demands of estrogen for puberty, menstruation, pregnancy, and lactation. The peak age of frequency of thyroid neoplasm in our study was 21 to
1 minute to go. Please continue.
In our study, malignant lesion predominant over benign lesion. Follicular variant of PTC is the commonest variant of papillary thyroid carcinoma, and it is comparable with other studies. Comparison of our study with the other study results. The study concluded with female preponderance, female to male ratio is 5.9:1. Common age group is 3rd to 4th decade. Malignant thyroid neoplasm were common than benign. Commonest benign neoplasm was follicular adenoma. Commonest malignant were papillary thyroid carcinoma, followed by medullary thyroid carcinoma and follicular thyroid carcinoma. The prognostic factors such as tumor encapsulation, capsular or vascular invasion, lymph node metastasis, necrosis can be evaluated based upon histomorphology alone. The present study highlights the importance of histomorphological typing of thyroid lesion for their better management. The limitations of our study: molecular and cytogenetic characterization of thyroid neoplasms were not studied. Long-term follow-up is needed for further study of the prognostic factors. These are the references of my study. Thank you.
All right, Dr. Swati, it's okay.
Yes, sir.
You have done statistics of the thyroid lesions or thyroid malignancies. You have not studied the inflammatory disorders, I suppose, no?
Yes, sir.
Have you have any lesion papillary carcinoma with the Hashimoto's?
Yes, sir. Yes.
You were having Hashimoto's with the papillary carcinoma in your case?
Yes, sir. I found in 1 to 2 cases. Out of 90, 1 to 2 cases was the Hashimoto thyroiditis in the background of papillary thyroid cancer.
Achha. So Hashimoto's was not associated with the follicular or any other type of malignancy? It was,
No, sir.
no, it was only papillary?
Yes, sir.
Okay, okay, all right.
Okay. Dr. Swati, nice presentation and no question. Your images was really good. Thanks.
Okay, so we conclude this session here.
Yeah.
I thank the presenters and the judges for this wonderful session. Ankita?
Thank you. Thank you, Pradeep Umap sir, and thank you, Anjali Bode madam. Thank you, Swati ma'am, for this wonderful session. Over to you, Shraddha, for the next session.
Thank you, Ankita ma'am. Good evening, everyone. So now we'll be commencing with the third session and the final session of the day, that is the histopathology paper presentation. We have amongst us senior histopathologists and our beloved teachers and mentors, Dr. Pratibha Davande madam and Dr. Sadhna More madam, as judges for this session. We welcome you both, ma'am. A gentle reminder and a humble request to all the presenters. You will be allotted a time limit of 10 minutes, that is 7 minutes for presentation and 3 minutes for discussion. So please abide by this time limit. So we'll start with our first presenter, that is Dr. Bharti Thakur. Dr. Bharti, I request you to kindly share your screen.
Good evening, everyone. My topic for paper presentation is study of expression of Ki1 in breast carcinoma. Introduction: breast cancer, the most common cancer type and the leading cause of cancer.
Sorry to interrupt you. We cannot view your screen.
Oh, okay.
Yes, please share your screen.
Is it visible?
Yes, it's visible. Please toggle it to slideshow mode.
Good evening, everyone. My topic for paper presentation: study of expression of Ki1 in breast carcinoma. Introduction: breast cancer, the most common cancer type and the leading cause of cancer-related death in women worldwide, and it accounts 14% of cancer in Indian women. According to 2018 breast cancer statistic, 1,62,468 new cases were registered and 87,090 deaths were reported. Ki1 is a metastasis suppressor gene and is derived from Chinese word kangai, which means anti-cancer, and it is a member of tetraspanin family that was first identified in T-cell activation study and is localized on cell membrane and in cytosol, and is present on chromosome 11p with 10 exons and 9 introns spanning 80 kb. Ki1 gene interacts with large number of proteins including integrins, epidermal growth factor receptor, G protein coupled receptor, and is involved in regulation of cell proliferation, cellular motility, cell differentiation, and cell-cell interaction. And the altered expression of Ki1 lead to decrease in addition, increase in invagiveness of cancer cells. Ki1, which is also known as CD82, is an established metastasis suppressor that has been documented to be lowly expressed in metastatic breast cancer and is highly expressed in normal breast tissue. Hence, Ki1 could possibly be a feasible molecular target for impeding metastasis in breast cancer patients. Therefore, a study has been undertaken to know the expression of Ki1 in cases of breast carcinoma in tertiary care hospital of ABBRH. Our aim is to access the relationship between Ki1 protein expression and clinicopathological parameters in breast cancer patients. Objectives are to confirm and diagnose carcinoma breast by histopathological examination and to determine the histological grade by Nottingham histological grading system, to determine the staging of carcinoma breast by TNM classification, which is based on AJCC, to assess Ki1 protein expression in tumor tissue of breast carcinoma by immunohistochemistry, and to correlate between Ki1 protein expression with clinicopathological parameters in breast cancer patients. Material and methods. My type of studies: observational, analytical, and cross-sectional. Study comprised of 30 breast cancer cases. Formalin fixed and paraffin embedded blocks of tumor masses from resected modified radical mastectomy specimen were taken. 10% formalin, grossing instruments, automated tissue processing assembly, HNA stain, Ki1 marker, glass slides, and binocular research microscope. Inclusion criteria includes all the cases diagnosed as carcinoma breast, all modified radical mastectomy specimen, all female patients presenting with carcinoma breast, primary cases of carcinoma breast without any history of previous treatment. Exclusion criteria: all cases of myoepithelial lesions, mesenchymal tumors, fibroepithelial tumors, tumor involving nipple, malignant lymphoma, metastatic tumor, and adenomas. Cases where true cut biopsy, wedge biopsy, lobectomy has been done were excluded. Male patients with carcinoma breast were excluded. Cases with recurrence or history of neoadjuvant therapy were excluded. Approach to my study: informed consent and clinical history were taken. Confirmed and planned modified radical mastectomy specimen for histopathological examination were received and kept in 10% formalin for 12 to 24 hours. Then dissection were done and routine staining were done. The grading of tumor will be determined by Nottingham histological grading system, and TNM staging is done. Immunostaining for Chi1 will be carried out to evaluate Chi1 expression in each case, and after which correlation of Chi1 protein expression of each case with clinico-pathological parameter in breast cancer patient will be done. Evaluation of Chi1 protein by CD82 to immunohistochemistry. For each slide, a value designated H-score obtained by application of following algorithm. H-score equals to summation of intensity and into percentage of staining. A specimen with H-score, if it is more than or equal to 50, will be classified as Chi1 positive, and if it is less than 50, it will be classified as reduced. Intensity, if percentage of staining is less than 10%, will show no staining. If it is between 11 to 50%, shows weak staining, and if it is between 51 to 75%, will show distinct staining, and if it is more than 75%, will show +3 very strong staining. In table 1, clinical pathological data of breast cancer patient were used. Characteristic taken were age, menopausal status, tumor size, node status, metastasis, stage, and histological grade. In age less than 45, 13 patients were there, and in more than 45, 17 patients were there. In pre-menopausal status, 13 patients were there, and in post-menopausal, 17 patients were there. In tumor size, 4 patients were in T1 stage, 16 were in T2, 7 were in T3, and 3 were in T4 stage. Node status, 5 were in N0 status, 8 were in N1, 11 were in N2, and 6 were in N3 stage. In metastasis, 22 were in M0 status and 8 were in M1. In staging, 6 were in stage 1, 5 patients were in stage 2, 14 were in stage 3, and 5 were in stage 4. In histological grade, 7 were in grade 1, 12 were in grade 2, and 11 were in grade 3. After correlation of Chi1, with clinico-pathological parameters, in age less than 45, 8 were showing positive expression and 6 were showing negative expression. In more than 45, 7 were showing positive expression and 9 were showing negative expression. In premenopausal status, 6 were showing positive expression and 8 were showing negative. In postmenopausal status, 9 were showing positive expression and 7 were showing negative expression. In tumor size T1, 3 were showing positive expression and 3 were showing negative expression. In T2, 6 were positive and
1 minute to go, Dr. Bharti. Please continue.
Yes, ma'am.
You have 1 minute to go. Please continue.
4 were showing negative expression. 3 were in T3. 3 were showing positive and 5 were showing negative expression. T4, 3 were showing positive and 3 were showing negative expression. In node status N0, 2 were showing positive and 3 were negative expression. In N1, 5 were showing positive and 4 were showing negative expression. In N3, 3 were showing positive and 3 were showing negative expression. In N4, 5 were showing positive and 5 were showing negative expression. In M0, 11 were showing positive expression and 10 were showing negative expression. In M1, 4 were showing positive expression and 5 were showing negative expression. In stage 1, 2 were showing positive expression and 3 were showing negative expression. Stage 2, 3 were showing positive expression and 7 were showing negative expression. In stage 3, 7 were showing positive expression and 2 were showing negative expression. In stage 4, 3 were showing positive expression and 3 were showing negative expression. In histological grading, 5 were showing positive expression and 3 were showing negative expression. In grade 2, 6 were showing positive and 6 were showing negative expression. In grade 3, 4 were showing positive and 6 were showing negative expression. Chi1 expression was...
Conclude, Dr. Bharti.
Yes, ma'am.
You're exceeding time limit. Request you to please conclude.
Ma'am, coming to the conclusion.
Thank you.
in figure 1 showing negative immunostaining, and in figure 2 showing 10 to 25% of immunostaining of Chi1. Discussion. The abrupt rise of breast cancer incidence among women has made it leading cause of morbidity and mortality globally, leaving behind cervical cancer. This unfortunate development has triggered a disheartening need for identification of novel markers which can fruitful in designing remedial measures for breast carcinogenesis. Present data showed that the expression of Chi1 protein was also downregulated in highly malignant breast cancer cell lines and specimens. Most strikingly, most pleomorphic tumor cell had significantly lower level of Chi1 protein as compared with lower grade tumor or normal ductal cell in the same specimen. Therefore, within an individual, Chi1 expression was also inversely correlated with the severity of tumor. In summary, our results, which are consistent with most of the current literature, support the role of Chi1 as a favorable prognostic factor for a variety of human cancers. Study done by Zhang et al. Entitled Expression of Tumor Metastasis Suppressor Gene Chi1 and Matrix Metalloproteinase 2 in Breast Cancer Tissue demonstrates that there is downregulated in Chi1 expression downregulated in breast cancer, and the patient with lymph node metastasis shown decreased Chi1 expression as compared to patient without lymph node metastasis. Study done by Huang et al. Demonstrate disease-free survival rate of patient with Chi1 negative tumor was significantly lower than that of patient with Chi1 positive tumors. Study done by Yang et al. Demonstrates significantly high expression level of Chi1 in normal breast tissue and benign breast tumors than in breast cancer. In conclusion, there's decreased expression of Chi1 protein and those cancer with high aggressiveness and a poor prognosis. Chi1 metastatic suppression ability in conjunction with other markers can also be used as marker of therapeutic potential. Apart from clinical trial, the role of Chi1 in various cellular signaling pathway in an area that requires further investigation. Conclusively, these results provide clinical evidence to support that Chi1 is a breast carcinoma metastatic suppressor gene. Measuring Chi1 expression will help to identify those breast cancer patients with metastatic propensity and hence guide clinicians to risk stratify their patient and need for close follow-up and aggressive treatment plan. These are the references. Thank you.
Thank you, Dr. Bharti.
Hello,
moving on to the discussion.
Hello, Bharti.
Yes, ma'am.
Good presentation. But why have you excluded male patient?
Ma'am, male patient were not taken.
Why? Because your main means what's for metastasis, no? And in which other organ it has been studied? Chi1.
Ma'am,
Any other
MRM cases, ma'am.
No other organ. Any other organ, because metastasis can occur in other organs.
Other organ like lungs, intestines,
stomach.
Yes, ma'am. Stomach also.
Okay. Thank you.
Hello, Bharti.
Yes,
the same question I was going to ask you. Why have you excluded any male patients? I mean, was there any scientific reason not to include the male patients? Or you didn't find any male patients in your 30?
No, ma'am. We didn't find any male patients.
So that was not the exclusion criteria, no? Because you have not found, you have not included. Is it so?
Yes, ma'am.
Because you have written it in an exclusion criteria. Anyway, I would like to know what is the practical application of your study? I mean, are you going to do every Chi1 in every MRM specimen? Are you advising that?
Ma'am, measurement of Chi1 will identify the metastatic propensity in breast cancer patient, and it will guide the clinician to stratify their patients and need for close follow-up for aggressive treatment plan.
Okay, okay. Thank you so much. Nice presentation.
Thank you, ma'am.
Thank you, Dr. Bharti. Thank you, dear judges. Our next presenter, Dr. Gauri Kulkarni, has not logged into the session. So moving over to our next presenter, Dr. Pooja Shinde. Dr. Pooja, are you here with us? Dr. Pooja Shinde?
Yes, ma'am.
Yeah, please share your screen.
Yes. Good evening, everyone. Good evening, everyone. My topic of today's presentation is histopathological study of cholecystectomy specimen. Introduction. Gallbladder disease remains one of the most common medical problems requiring surgical intervention, as the gallstones are one of the major causes of
morbidity and mortality all over the world, affecting 10% of adult population. Cholecystectomy is one of the most frequently performed emergency abdominal operation. Cholecystectomy performed with provisional diagnosis of benign diseases based on clinical, ultrasonological, and computerized tomographic scanning misses a significant number of early malignant lesions of gallbladder. Histopathological study is the gold standard for diagnosis of gallbladder lesion as it provides the definitive diagnosis. The aim was to study the histopathological patterns of gallbladder lesions in cholecystectomy specimen received in our histopathology section. It is a prospective type of study which is carried over a period of 1 year from January 2021 to December 2021. The total cases studied were 55 cases. Inclusion criteria: all cholecystectomy specimens which were received in our department was included. Exclusion criteria: gallbladder excised with duodenum and pancreas, like Whipple's procedure. Every cholecystectomy specimen were collected in 10% formalin. The specimen were fixed in formalin for 20 to 24 hours. Detailed cross-examination of all the specimens were done. 3 sections were taken, each from fundus body and neck. Additional sections were taken if there was a focal lesions were present. These were followed by routine tissue processing. Observation and results. The total cases were 55 with mean age of 45 years. The female to male ratio was 3:2. The youngest patient was 15-year-old and the oldest patient was 74-year-old female. The most common age group affected was between 31 to 50 years with total percentage of 46%. The various procedures performed were laparoscopic cholecystectomy with 48 cases, open cholecystectomy with 5 cases, open cholecystectomy with extended hepatectomy 2 cases. The various histopathological findings were chronic cholecystitis with 89.2% of the cases, acute cholecystitis with 1.8% of the cases, xanthogranulomatous cholecystitis with 3.6% of the cases, adenocarcinoma which was preoperatively diagnosed with 3.6% of the cases, adenocarcinoma which was incidentally diagnosed with 1.8% of the cases. Association with gallstone. Out of total 55 cases, 52 cases were associated with gallstone. 3 cases were of acalculous chronic cholecystitis. Chronic cholecystitis on gross, serosal and cut surface shows thickened gallbladder wall. On microscopy, focal ulceration of mucosa with transmural lymphocytic infiltrate and congested blood vessels. Xanthogranulomatous cholecystitis on microscopy shows foamy histiocytes in the background of inflammatory cells. Gallbladder carcinoma. Total cases studied were 3. Out of which 2 cases were preoperatively diagnosed and operated as open cholecystectomy with extended hepatectomy. 1 case of gallbladder carcinoma was clinically diagnosed as chronic cholecystitis, and histopathology showed features of adenocarcinoma, which was operated as laparoscopic cholecystectomy. Thus, out of 3 cases, 1 case was incidentally diagnosed as adenocarcinoma. The CT findings were mass lesion in the body of gallbladder, and there was subtle thickening of gallbladder wall. On gross, thickened gallbladder wall with ulcerated mucosa. Microscopy shows malignant cells which are arranged in glandular and papillary pattern. Tumor cell shows round to oval, pleomorphic, hyperchromatic nuclei with mild eosinophilic cytoplasm. Tumor is infiltrating the underlying muscularis mucosa. Discussion. It is well known that gallbladder diseases affect more frequently women than men, occurring most frequently in middle-aged population. In this study, the female to male ratio was 3:2 and most commonly affected age group was 31 to 50 years. These findings were comparable with other studies. The most common histopathological finding in our study was chronic cholecystitis, accounting to 89% of total cases. Gallbladder carcinoma cases accounted for 5.5% of total cases with female preponderance. Carcinoma was seen in elderly patients with age group of 55 to 65 years. The other studies shows the results of this study was compared with other studies, and it was seen that chronic cholecystitis was most common finding in all the studies with most common age group of 31 to 50 years. This study shows little high in a percentage of gallbladder carcinoma accounting for 5.5% of the cases and xanthogranulomatous cholecystitis with 3.6% of the cases. The VAPM study shows high percentage of acute cholecystitis. Discussion. So, according to Consolidated Report of Population-Based Registries of India, 2009-2011, India has shown high incidence of gallbladder cancer in female population of Assam, which is highest among the world. In 15 to 30% of the cases, there is no evidence of malignancy before or during the operation, and the disease is diagnosed microscopically post-operatively. Conclusion. The dominant diagnosis was of chronic calculous cholecystitis with female preponderance. Clinical presentation and radiological findings are generally vague, subtle, and non-specific, even in malignant lesions of gallbladder. Therefore, to avoid missing of gallbladder carcinoma and its bad consequences, a detailed and meticulous histopathological examination of every cholecystectomy specimen is important in the treatment and prognosis of patient. These are my references. Thank you.
Thank you, Dr. Pooja. Over to the judges.
Thank you.
Hello, Pooja. Good presentation.
Yes,
So cholecystitis is what's very common, na?
Yes.
So which type of stones were mostly associated with?
Mostly cholesterol stones were associated.
So have you collected that data? Which means cholelithiasis? Which type of cholelithiasis was common? Because sickle cell and other hemolytic diseases are also common here.
Yes, ma'am. Actually, 30% of the cases were of cholesterol cholelithiasis, and 25 was of pigmented stones.
So you have studied the spectrum of diseases. So what are the any interesting case worth mentioning?
Ma'am, interesting case was one which was preoperatively diagnosed as chronic cholecystitis, and on histopathology, it was diagnosed as gallbladder carcinoma, adenocarcinoma.
Yes, many times it is occult or in thickened gallbladder we get it. Okay, thank you. Good presentation.
Thank you.
Thank you, dear judges. Thank you, Dr. Pooja.
Thank you.
Now moving over to the next presentation by Dr. Sabya Varshine. Dr. Sabya, I request you to please share your screen. Dr. Sabya Varshine.
Ma'am, am I audible?
Yes, you're audible. Please proceed.
Ma'am, I'll be just sharing the screen. I guess the previous participant hasn't yet left it. Hello?
Hello.
Haan
I
ji,
request
ma'am,
Dr. Pooja Shinde. Dr. Sabya, are you able to share your screen?
ma'am, just a sec.
Yes.
Ma'am, is it visible?
Yes, it's visible. Please toggle it to full screen mode.
Should I start?
Yes, please start.
Okay. So, good evening, teachers and everybody. Today I'll be presenting my paper on the topic Evaluation of Immunohistochemical Expression of BCL2 in Oral Squamous Cell Carcinoma. So starting with the introduction, oral cancer is one of the most common cancer globally, and in year 2020, cancer of oral cavity and pharynx collectively contributed to...
Dr. Sabya?
Yes, ma'am?
We are not able to see the full screen mode. And you
slide mode pe jahiye, please.
Change the slide as well.
Okay, ma'am. Actually, I started here. I think it will take time. It's all visible. Is
Make
it visible now?
full screen. Make it full screen.
Ma'am, just a sec.
Okay, it's okay for me. Ask Pratibha Davande, madam.
Okay, yes. Okay, you go ahead.
Okay, go ahead.
Go ahead.
Okay. So in the recent years, a number of proto-oncogenes have been identified that are known to prevent apoptosis or programmed cell death. It has also been highlighted that these altered expression could result in dysregulation of this process, and BCL2 has been identified to play a role in regulating apoptosis. Increased expression of protein product of BCL2 gene appears in the early phase of carcinogenesis, leading to apoptosis deterioration and consequence to the progression of neoplastic change. In many earlier studies, overexpression of BCL2 has been demonstrated in carcinoma of nasopharynx, lungs, colorectum, prostate, stomach, and esophagus. And in addition, overexpression has also been observed in precancerous lesion. This suggests that BCL2 may be associated with early oncogenesis in these organs. Hence, the present study was carried out to evaluate immunohistochemical expression of BCL2 in oral SCC in order to correlate expression with different grades of oral squamous cell carcinoma, mitotic index, lymphovascular invasion, perineural invasion, pathological stages, and lymph node status. Starting with the material and method. So this study was carried out in the Department of Pathology of SRMS IAMS Bareilly over a period of 1.5 years. Total number of cases were 42. And in the inclusion criteria, we took histopathologically confirmed wide local excision cases of oral SCC with neck dissection submitted in the department, and exclusion criteria, punch biopsy and wide local excision without neck dissection were excluded from our study. So histopathologically, the lesions were graded as well, moderate, and poorly differentiated respectively according to the differentiation of cells to that of epithelial cells using Broddel's classification. And lymphovascular and perineural invasion, if any, were recorded. The tumor mitotic index and index of atypical mitosis was assessed, and the following criteria was given as score 0 if no mitosis, score 1, 1 to 5 mitosis, 2, 6 to 10, and score 3 more than 10. And it was evaluated in at least 100 neoplastic cells per sample using light microscope at 40x magnification. IHC was done using quartet GmbH immunodiagnostica kit, and the immunohistochemical assay was done as per instruction of the kit, and the staining was graded using the following criteria: percentage of positive cells. If more than 50% of cells were positive, then 3+, 25 to 50% positive, 2+, 5 to 24% cases positive, 1+, and if fewer than 5 or no staining, then negative. These were the few microscopic images captured by me. And here we can see this is well-differentiated squamous cell carcinoma on 40x HNE, poorly differentiated squamous cell carcinoma.
Actually, images and everything is not seen. Now,
yes,
only
we are not able to see your screen, Dr. Sabya.
We are seeing only the first slide, I think.
Yes, ma'am.
In my this thing.
Yeah,
yes,
yeah.
Thank you. Yeah, it's better.
It's not moving. Slides are not moving.
Yes, yes.
I'll just do once again, ma'am. Ma'am, are they visible?
Yeah.
Yes, they are visible now.
Yes.
Can you see?
But still you are not able to go on the slides show mode.
Now, is it?
Yeah, slides are visible, but
it's not on.
Ma'am, actually, I have already started slide share from here. I don't know what technical.
Okay. Go ahead.
Fine.
Okay, ma'am. So these were the cases, and well-differentiated squamous cell carcinoma, and then this was poorly differentiated. And then on the BCL2 IHC, the immunoexpression was seen as 1+ here, and in the second figure, we can see expression as 3+ on 10x. So these were the results. The age of patient ranged from 27 to 75 years, with the mean age of patient with 49 years. Majority of cases were males, 83.3%. There was a dominance of well and moderately differentiated cases. Lymphovascular and perineural invasion was seen in 16.7 and 26.2 cases. Majority had a mitotic index 2 and pathological T stage 3 and 4, and no nodal involvement was seen in 54.8 cases. PCL2 expression was seen in 34 specimen, that is 81%, and there was no significant association of age and sex with BCL2 expression with p-value more than 0.05. With increasing histopathological grade, mitotic index, and PT, there was a significant increase in BCL2 positive expression. However, LVI, PNI, and PN status did not show a significant association with BCL2, with p-value more than 0.05. So here's a histogram showing dispersion of age of patients with a mean age of 49 years. Here this is pie chart for distribution of cases according to the histopathological grade. Grade 1, 38.1%, grade 2, 42.9%, grade 3, 19%, and distribution of cases according to pathological T stage, PT1, PT2, PT4, and PT4. Distribution of cases according to pathological and nodal status, N0, 54, N1, 11.9, N2, 13, and 31, and N3 as 2.4. Then this was the immunohistochemical expression of BCL2, no expression in 8 cases, +1 expression in 6 cases, +2 in 15, and +3 in 13 cases. So this was association of BCL2 expression with histopathological profile of oral SCC. Here we can see that BCL2 expression status according to the various grading 1+, 2+, and 3+, and it has a statistical significance of 0.001, mitotic index having a 0.045 significance, and a PT state showing 0.008. So coming to the discussion, in the present study, BCL2 positive expression was seen in 81% of specimen, and 2/3 of these cases had BCL2 expression score 2 and 3, and similar to the present study, Solomon et al. And Sutaria et al. Had reported high BCL2 expression. Rahmani et al. In their study reported BCL2 immuno expression in 51.7 of their cases, with 1+, 2+, 3+ immuno expression in 15 and 23 cases respectively. Juneja et al. On the other hand reported BCL2 positivity in only 30% of oral SCC cases, with 1+, 2+, and 3+ expression in 16.1.
Time limit. I request you to please conclude.
Okay, ma'am. So this is the conclusion. In the present study, there was a significant association of BCL2 expression with increasing histopathological grade, pathological T stage, and mitotic index, and no significant association of BCL2 expression with age, sex, LVI, PNI, and PN stage, and number of metastatic lymph node was seen. In conclusion, BCL2 might be used as a prognostic indicator for oral SCC, which was also suggested by other studies, and limitation of our study were absence of a control group and small sample size. Prognostic value of BCL2 is also recommended to be studied in longitudinal studies with follow-up, and further studies on a larger sample size are recommended. These were the references used, and thank you for your time.
Good presentation. Thank you.
Nice presentation, Sabya.
Thank you,
And
ma'am.
Images, only thing your slideshow could have been give us a better this thing. Now, in the oral squamous cell carcinoma, as you know, the causative factors, have you ever thought of कि आपके यहाँ कितना ज़्यादा था, and tobacco and all these this thing?
Yes, ma'am. In majority of the cases, as I read the file, so in majority of the cases, around 81% or something, it was associated. The patient had a history of either tobacco chewing and or cigarette smoking.
Fine, fine. And you said that it is essential for the prognostic of the prognostic value. So what is the practical application? Just as the therapy is going on, are we going to do it? Are you advocating to do it, BCL2?
Yes, ma'am. It can be used as a prognostic indicator. Actually, according to my study also, the limitation was also that I didn't put dysplasia in it. So it could have been a better study if I did that dysplasia and oral SCC. And as well as it can be used to differentiate, because in my study, it showed a higher BCL2 expression in poorly differentiated. So,
Hello. Hello. You said that it is not statistically significant in LVI, PNI, PN. What can be the logical explanation behind that?
Ma'am, actually, the logical explanation, ma'am, because I didn't study any cases in which it was majority of my cases had a LVI and PNI not seen status, ma'am. So I don't really know the.
Then how can you calculate whether it is statistically significant or not?
Because I found that in my study, ma'am, like I looked for LVI and PNI. So according to my study,
LVI was not there, and that was also not there. Then how can you say? Okay, now you calculated mitosis per hyperfield or per mm square?
Ma'am, I calculated it on 40x.
Okay, good.
Thank you.
Thank you, dear judges. Thank you, Dr. Sabya.
Thank
Moving
you.
over to the next presentation by Dr. Shraddha Toshniwal. Dr. Shraddha Toshniwal, I request you to kindly share your screen. Dr. Shraddha, are you here with us?
My voice is audible?
Yes, it is audible, doctor.
Slides are visible, ma'am?
Yes, slides are visible. Please toggle it to full screen mode.
Okay, ma'am. Yes, ma'am. These slides are visible? Yes, ma'am.
It's taking time, Dr. Shraddha.
Yes, okay, ma'am. Good evening, ma'am.
Could you please try again?
Start.
Myself, Dr. Shraddha Toshniwal, presenting a paper for title is Histopathological Study of Neoplastic Lesions of the Breast. So, introduction. Female breast composed of various structures giving rise to different types of lesion and lump. The lesion of breast can be of various types ranging from inflammatory, benign, malignant, with some lesion being common in young female, while other being common in elderly to older age group.
Sorry to interrupt you, Dr. Shraddha.
Yes, ma'am.
Can you change the slide?
Yes, ma'am.
Can you please change the slide? Can you move over to your introduction slide?
Yes, ma'am, I can change.
Slides are not moving. They are
Yes,
not
slides are
moving for us.
Okay, ma'am. They move.
They are
As
not moving
the
for
last
us.
presentation, even
Ah,
slides are not
same
moving.
problem was there in last presentation.
And they
Yes,
are not
ma'am.
on the full mode.
Slides are visible?
Slides are visible, but they are not moving.
Not moving, yes. Yes, doctor.
So there is first slide only.
Okay, ma'am.
Dr. Shraddha, are you facing some technical problem?
Yes, ma'am. All.
Do you want to present after some time?
Yes, ma'am. Okay.
Okay, we'll take your presentation later.
Okay.
Moving over to our next presenter, Dr. Supreet Olaf would not be joining us today. So our last presenter is Dr. Suraj Chikalgar. Dr. Suraj, are you here with us?
Yes, ma'am.
Dr. Suraj, please share your screen.
Yes, ma'am. Am I audible?
Yes, you're audible, doctor.
You're audible.
Yes. Good evening, everyone. Topic for my today's oral presentation, that is spectrum of mesenchymal lesions of the digestive tract.
Dr. Suraj, please share your screen. We are not able to view your presentation.
I had actually started sharing.
No, we are not getting it.
Is my screen visible?
No, no.
No.
Kindly just close and then reopen. It might help. Are you seeing the share screen option at the top or at the bottom?
Shraddha?
Yeah. I am seeing it at the bottom.
Hello, Shraddha. Can you place slide for them? Are you having their presentation?
I'll request you. Yes, ma'am.
Now your screen is visible.
Yes, ma'am. Okay, ma'am.
Yes, Dr. Suraj, please proceed.
Yes, ma'am.
Yes.
So the topic for my today's oral presentation is spectrum of mesenchymal lesions of the digestive tract. So mesenchymal lesions of gastrointestinal tract, though uncommon, display a wide variety of lesions encompassing benign, intermediate, and malignant entities. As majority of them present with overlapping histomorphological features, diagnosis of this tumor is essential and can be benefited with specific targeted therapy. Present study comprises of 14 cases of mesenchymal lesions of gastrointestinal tract. Study was done in a histopathological section of Department of Pathology at Institute of Medical Science and Research, Mulana, Haryana. All cases of mesenchymal soft tissue tumors of GIT over a period of 2 years from June 2019 to July 2021 were included in the present study. The hematoxylin and eosin stain slides were retrieved from the records and reviewed by 2 pathologists.